All right, good morning to everyone. A special welcome to our council members and to the NINR science community. The meeting is being videocast live and will be archived on the NIH Videocast website. So thank you everyone for joining us today. So before we get started, I'd like to welcome our new members. So Dr. Vincent Guillermo Ramos is recently appointed director of the Institute for Policy Solutions at Johns Hopkins School of Nursing. He previously served as dean and distinguished professor of the Duke University School of Nursing and vice chancellor for nursing affairs, where he realigned the school's mission and strategic plan to advance health equity and social justice. Dr. Guillermo Ramos studies the role of families in promoting adolescent health, and he led the development of the framework for harmful social determinants of health mitigation, an innovative roadmap for those designing programs to mitigate adverse social determinants of health. He serves on several advisory boards, HHS panels, and boards of directors. Welcome, Vincent. Dr. Jing Wang is Dean and Professor at Florida State University College of Nursing. Her research uses mobile and connected technologies to optimize lifestyle interventions and improve patient-centered outcomes in chronically ill and aging populations, especially among rural and underserved populations. She pioneers artificial intelligence in nursing and smart home innovations for aging in place and care at home delivery models. She serves as board of trustee at the Robert Wood Johnson Foundation and HCA Florida Capital Hospital. So welcome, Dr. Wang. So welcome to you both. Welcome to council. We are delighted to have you and look forward to working with you. So I'd also like to welcome an ad hoc member for this meeting. Dr. Marie Lynn Miranda is Chancellor of the University of Illinois, Chicago. She is an economist and leader in the field of geospatial health informatics and is known for her work in childhood-led exposure and climate change. Chancellor Miranda is the director of the Children's Environmental Health Initiative, a research, education, and outreach organization committed to fostering environments where all people can prosper. Welcome to you, and thanks for joining us. So this will sadly be the last meeting for several of our council members. Dr. Mallory Johnson, Dr. Christopher Lee, and Dr. Cindy Monroe are joining us today for the last time. Dr. Elias Provencio Vasquez couldn't make today's meeting, but it would have been his last council meeting as well. We do want to thank you all for your service to NINR. They've served on our advisory committee since 2021. I personally have really enjoyed the opportunity to work with each of you. And I would like to extend a special congratulations to Dr. Cindy Monroe. She is retiring from a distinguished career in nursing science in just a few short days. And so a special congratulations to you and recognition for your long and impactful career. Thank you. So I will turn the meeting over to Dr. Elizabeth Tarlov, our Executive Secretary, who will proceed with the roll call.
Extenuating circumstances, Dr. Stone has joined us remotely today. Dr. Stone, can you turn on your camera and say present or here?
Here, I can barely hear you, but I'm here.
Thank you. You should hear me better now that I've managed to turn on my mic. Thank you. Thank you, Dr. Stone. All right, proceeding with the roll call now, I ask that the council members here on the NIH campus in Bethesda, please raise your hand or say present or here when I call your name. Dr. Atkins. Here. Dr. Ayala.
Present.
Dr. Beckemeyer.
Here.
Professor Dawes. Dr. Fitzpatrick.
Present.
Dr. Guillermo Ramos. Dr. Johnson. Dr. Lee. Dr. Monroe. Dr. Wang. And I note that Dr. Sullivan is present as ex officio for the Chief Nursing Officer, Department of Veterans Affairs, and Lieutenant Colonel Gardner is present as ex officio for the Assistant Secretary of Defense for Health Affairs. Dr. Zank, we have a quorum for this meeting. I'll now turn to a vote on minutes from the last council meeting. Minutes of the January meeting were made available in the electronic council book for your review. May I have a motion to approve?
Move to approve.
A second?
Second.
Thank you. Any discussion? Any opposed? Motion carries. And now we'll move on to a few words on meeting logistics. Slide, please. Thank you. Council members, when you speak, please use the push to talk feature on the microphone in front of you to ensure that everyone can hear you. And please turn off your microphone when not in use. This is a one-day meeting. As always, a recording of this meeting will be made available at the address shown on the slide. Closed session will begin approximately 15 minutes following the end of open session. Next slide, please. Dates for future council meetings are listed on the NINR Council webpage, as well as in the open session materials in the electronic council book and shown here. Please add these dates to your calendar. Our next meeting is scheduled for September 12th, 2024, and will take place here in person in Bethesda. I would like to remind council members, other than our ex officio members, that you are special government employees. As such, you may not engage in lobbying activities while receiving pay from the federal government. Information regarding conflict of interest and confidentiality requirements are posted in the electronic council book, so please review those if you haven't done so already. I will give more specific instructions about conflict of interest and confidentiality at the beginning of the closed session later this afternoon. Now I'll turn it back to Dr. Zank for the NINR Director's Report.
Okay. I will get started. So as I was putting together the update for today's meeting, it really struck me what an exciting time it is to be thinking about implementation of our strategic plan. The work that we're doing at the Institute under the strategic plan really is truly moving us forward in our mission of optimizing health and advancing health equity into the future. So let's start with some of the ways that NINR is advancing science since January through funding opportunities, scientific events, and publications. So at the January Council meeting, we cleared the concept of expanding research to advance health equity in rural populations. Although Council approval may or may not lead to a new funding opportunity, this concept did. So through this RFA, NINR is supporting the development of interventions, making significant, sustainable improvements in health outcomes of rural populations. Rural populations, as you probably know, make up 20% of the U.S. population. They experience high rates of morbidity and disability, as well as increasing rates of premature death. So here we solicited research centered on intervention strategies addressing social determinants of health to improve health and promote health equity. It encouraged studies that harness a wide range of methods and approaches, including community-engaged approaches that build on the strengths of rural communities. Applications were due just last week, and we are looking forward to the research that we will fund in this area. So just as a reminder, we do post all approved concepts on our website. So if you're interested in a recap of the science areas that were discussed during a previous council meeting, you can check there. NINR is the lead institute on another new funding opportunity that I am really excited to tell you about, which is related directly to our mission and strategic plan. Research shows that intersecting systems of privilege and oppression produce and sustain wide and unjust variations in health. So this funding opportunity, called the ACCES Initiative, will support research to understand health at the intersections of race, ethnicity, socioeconomic status, sexual orientation, and ability by examining contributions of social determinants and other determinants of health. So why is this important? And more specifically, why is it important for NINR to lead? The reality is that we hold multiple statuses simultaneously that converge to influence our life experiences, but there's a difference in those experiences based on what statuses we hold. For minority groups, those experiences are too often embedded within systems of oppression that limit access to health promoting resources, services, and opportunities, and ultimately have downstream health consequences. So better understanding how these factors affect health at these intersections will enable us to design interventions that consider the whole of who we are as people. So the first application due date is July 5th. This is another example of a council concept that resulted in a funding opportunity. So this was cleared, you might recall, at the September 23 meeting. NINR is continuing to support the Small Business Innovation Research Program, along with several NIH institutes and centers, through a funding opportunity focused on eliminating health disparities. The purpose is to support small businesses in providing early stage investment funding for developing technology, services, and products that empower individuals and communities, including providers and healthcare institutions, that focus on populations that experience health disparities. The first application due date is coming up next month on June 10th. As with other grant opportunities, you can learn more on the NIH Grants website. We also have a section on our own website just about the small business program. In January, we shared the announcement of the first White House initiative on women's health research. Since then, the NIH Office of Research on Women's Health and other NIH institutes, including NINR, issued a notice of special interest to solicit research applications focused on diseases and health outcomes that predominantly affect women, present and progress differently in women, or are female specific. Projects accounting for social and structural variables are strongly encouraged. The first available due date was May 6th, and the NOC extends for a couple of more years through November 5th of 2027. Also related to the response to the White House Initiative on Women's Health Research, this funding opportunity that NIAAA is leading and NINR is participating in will support the planning phase of the Model Continuums of Care Initiative, which is a dissemination and implementation science initiative addressing multimorbidity in women and girls of reproductive age. It's intended to address gaps in the continuum of care by bridging evidence-based integrative interventions for mental health and substance use disorders and common co-occurring physical conditions to scale up at the population level. The establishment of public-private partnerships is a key activity in the planning phase. The first application due date is in June. So let's pause there. We just talked about two opportunities related to women's health research. It seems the NOC could be an opportunity for NINR. So how do you see NINR advancing women's health research? What are the most pressing issues you think that NINR can focus on or could consider when we think about women's health? I sprung it on you, right? Like, what are all your ideas on women's health research? Anything that comes to mind.
Shannon? This is Pat. Can you hear? Okay, can you hear me? Okay.
Yes.
One of the things that I think, which is just so appalling, is the health disparities in maternal health with Black American women, and you know, there's just so much I think NINR can do there because it fits its goal, its strategic plan. and I think it's something so much nurses care about. So.
Yeah, thank you for that.
One thing that comes to my mind are pharmacological differences in response, particularly with symptoms. I mean, there are marketed approaches, medications that, some evidence is coming out that women just respond differently. And I think understanding that is very vital.
I was just going to build on the first person, Pat, I believe, her comments. So I think broadly, sexual and reproductive health, I would comment on the issue around maternal-child inequities, but also the postpartum period and some of what we know there, the syphilis epidemic in the country, issues regarding the Dobbs decision and abortion, as well as HIV and the low uptake of PrEP among women. I think SRH is a huge area for women.
Yeah, and I think those are all great ideas. I think we have to remember that the leading cause of death and morbidity among women is a cardiovascular disease, and there are massive inequities and always have been that are seemingly getting worse. And it's occurring earlier in women than it has historically. So to keep that in mind, the prevalence of the leading causes of death.
This is Betty. I think it would, building off of the sort of reproductive health ideas too, it would be great if there could be some policy research, right? Variation in policy around reproductive health and its impact on maternal and child health, and disproportionately affecting people of color and low income, et cetera. But for taking a sort of policy lens on that would be terrific.
Those are great ideas. Thank you. Yeah. Commenting on the maternal health, hopefully everyone is aware we funded a large initiative, the AIM initiative, with a couple of rounds of funding, and so are supporting a number of projects on maternal health. So we look forward to sharing those results as they start coming in, but that has been a big investment for us, and we'll show you some data on that in just a minute. So thanks for that. All right, so moving along. Yes.
Do you view these two RFAs as limited to maternal health, or would it also include disparities in children or adolescents?
Those two that I just mentioned, the first one is very broad on women's health research, that NOCI, that's NIH-wide. The second one is focused on women and girls of reproductive age. The AIM initiative that we put out is focused on maternal health, but there's a wide variety of, and I think increasingly so, given this is a priority, of initiatives focused on women's health. And of course, people can always submit through the NOCI or through the parent mechanism too.
Thank you.
Yeah. Okay. So in January at our council meeting, we had a discussion on reaching audiences for funding opportunities and encouraging applications. So to address this, we have increased our outreach efforts in spreading the word about new funding opportunities, and have spent time providing additional education and support to potential applicants. So as an example of this, we held 4 technical assistance webinars since our last meeting. These webinars give potential applicants additional information about current funding opportunities and allow applicants to ask any questions they have. So I'm pleased to report there's been a lot of interest in these funding opportunities. For the Rural Health Technical Assistance webinar, we had 189 viewers. For the Transformative Research to Address Health Disparities, we had over 331 webinar attendees. For the Bridge to Care initiative, we had over 326 attendees. So we are very pleased with the response and the interest, and really appreciate your help in disseminating those funding opportunities. So the due dates for those opportunities have passed, but just this week we did hold a webinar about the Axes initiative that I mentioned a few minutes ago. So you can find recordings on our website. Again, thank you so much for your help in disseminating those initiatives. So we are also seeing publications that reflect NINR's work to advance the science, specifically in health equity and social determinants of health. So this paper from NINR grantees describes a cross-sectional study of over 10 million live hospital births in California over a 21-year time span. This study examined relationships between severe maternal morbidity and racial inequities in jail incarceration rates, which they used as an indicator of structural racism. They found that Black and Hispanic women in counties with high incarceration inequity had increased odds of experiencing severe maternal morbidity compared with those living in low inequity counties. The authors called for community-based alternatives to inequitable incarceration practices as a strategy to improve maternal equity. I also want to share a recent publication that Dr. Leo Saligan in our intramural division co-authored. Over 75 scientists and clinicians across 15 of the 27 institutes that comprise the NIH contributed to this multidisciplinary work. Post-infectious myalgic encephalomyelitis. Oh, I practiced. Okay, you know I do practice. Chronic fatigue syndrome, or PIMECFS, is a disabling disorder that is poorly understood and lacks proper treatment. The study used rigorous criteria to recruit PIMECFS participants with matched controls. The clinical abnormalities and biomarker differences provide new insight into the underlying pathophysiology of PIMECFS, which may guide future interventions. So congratulations to that team. Switching gears from publications to reports. At the January Council, we heard an update from the Climate Change and Health Working Group. This group met 4 times, you might recall, between September and November 2023, and discussed areas of critical need, gaps in current research, and future directions in climate change research. This work formed the basis for 9 recommendations for NINR-supported science in climate change and health research. Some top-line findings from the group are summarized on the slide. The 9 recommendations are detailed in a comprehensive report that will be posted on our website very shortly. So I want to again thank the members of that work group, in particular, Dr. Betty Beckemeyer here on Console, who served as a co-chair for that work group. So thank you again. Now, 2 years into our strategic plan, I want to spend a few moments highlighting our research portfolio as it stands regarding our investment as a percentage of our budget. So keep in mind as you look at these data that these categories are not mutually exclusive. A study can be classified in multiple ways, obviously. So for fiscal year 23, I'm proud to report that across the other ICs at NIH, we rank first and second in the sciences that are foundational to our work and aligned with our strategic plan. For example, NINR led the greatest investment in budget in clinical research and clinical trials, areas that have continued to be of great importance to the leadership at NIH. In fiscal year 23, NINR invested $129 million in behavioral and social sciences research, representing 65% of our budget. Looking across the NIH, you can see NINR ranks first, just ahead of NIMHD, NIAAA, and NIDA in this area, again, as a percentage of our budget. So when we look more closely at topics, you can see that NINR ranked second across the NIH in our investment in social determinants of health, health disparities, and minority health research. Dr. John Grayson will be talking more about the health disparities and minority health portfolio a bit later this morning. And Dr. Allison Colbert will be discussing NINR activities in the SDOH lens, through the SDOH lens later today. You can see our investment in maternal morbidity and mortality research. It has grown in recent years in concert with the deep concerns about worsening maternal health and related disparities in the United States. You can also see we have considerable equities in prevention, rural health, and women's health relative to NIH. So when we take a closer look at our investment in social determinants of health research, which, as you know, is one of our lenses in our strategic plan, NINR invested $93 million in this area, representing 47% of our budget in 23. Looking across NIH, you can see we're second in investment. Now, here's some change over time in this area of research. NIH started tracking this area of research just in 2020 was the first year. So you can see that 47% of our budget, again, is in social determinants of health research, which is more than double of what we spent just a few years ago. In fiscal year 20, only about 19% of our budget was in this area, and it's risen significantly as we've continued to implement our strategic plan. In terms of real dollars, the amount of money we've spent in social determinants of health has nearly tripled from $33 million in 2020 to $93 million in 2023. Shifting gears a bit, one of our goals as well has been to increase research with populations that bear the greatest burden of morbidity and mortality. As you may recall, fostering inclusion in our research is one of our guiding principles in our strategic plan, and it was the focus of a recent council work group. So we report on inclusion formally every 3 years, so that report will be coming next year. But given it is a priority for us, I wanted to check in to see how we're doing. So here's our inclusion data since 2016, shown for each racial and ethnic group as a percentage of the total enrolled in NINR supported studies that year. So you can see these data can jump around year to year a bit, partly because large studies begin or end over time. So while we still have considerable work to do, we are pleased to be seeing that we are trending in the right direction for several groups. Representation of non-Hispanic white participants has dropped from 70% in 2016 to 50% in 2023. The steepest rise in enrollment was among African Americans, which increased from just under 20% of participants in NINR funded research to over 30% between 2020 and 2023. And in 2023, enrollment of Hispanics in NINR supported research reached its highest level of this 9-year period. Since January Council, we hosted 2 NINR Directors Lectures. Our intramural fellows participated in an NIH Poster Day, and we have some upcoming events that you may want to attend or help us to spread the word about. So first off, I'm happy to announce a new event for the Institute that directly relates to our social determinants of health lens. So we are inviting prospective participants to submit letters of interest for our first Social Determinants of Health Summer Research Institute. This is a new event designed to provide early and mid-career scientists the opportunity to learn more about and apply the principles of high-quality social determinants of health research. The program is intended for scientists who have a strong foundation in social determinants, but are actively pursuing ways to include a greater emphasis on this in their work. So this event will take place at the NIH campus here in Bethesda in July. There's no cost to participate in the Institute. Selected participants will receive a stipend to help cover travel expenses. Eligibility and selection criteria are on our website, and the applications are due next week. So later in our agenda, again, we'll be talking more about all of our SDOH activities. Dr. Colbert will be expanding on this. We held our first Director's Lecture of 2024 in March. You might recall this year, that lecture focused on climate change and health. Dr. Julie Postema presented an overview of her research on the significance of heat trends and wildfire smoke on agricultural workers, with a focus on social determinants of health and the role of nursing research. We are pleased we had over 539 viewers of that webinar. So if you missed it, the recording is available on our website. Earlier this month, we hosted Dr. Stephanie Hawkins. She presented her work on firearm injury prevention and risk reduction interventions. Dr. Hawkins is the Vice President of the Transformative Research Unit for Equity, or TRUE, at Research Triangle Institute International, where she has worked for the past 20 years. She is a youth violence prevention and health equity subject matter expert. We received great questions, great discussion, and have received a positive response related to feedback. So as with this, you can find a recording on our website. And we are pleased to announce our upcoming lecture in July. This will focus on maternal health and how social determinants of health are central to this area of research. Our speaker will be Dr. Mahasan Majahid. Dr. Majahid is a professor of epidemiology at the School of Public Health at the University of California, Berkeley. Her primary area of research is in the area of social epidemiology, with a particular interest in investigations of neighborhood effects on health, cardiovascular health disparities, and racial ethnic health disparities over the life course. So this will be held on July 11th. Also this month, I am pleased to share 3 of our post-baccalaureate fellows presented posters on the research they are conducting at NINR. Pooja has been working on a study to quantify RYR1 gene expression in RYR1-RM patients using skeletal muscle biopsy samples. Myra has been busy looking at which dye is better at determining accurate measurement of calcium. Will is exploring sleep disturbance in men with prostate cancer by looking at data gathered by actigraphy and sleep diaries. So it was great to see them present their work to the NIH community. At NINR, we are looking always for ways to share our work and our opportunities with the larger scientific community. So here's a couple of activities. Community engagement is a priority for us, and we are emphasizing this in all of our activities. So in January, a few of us from NINR visited C3 Cares in Washington, D.C. C3 Cares was founded on the belief that everyone deserves access to convenient, quality health care. So we learned about their innovative model of nurse-led place-based care in public housing sites to increase access to health services and improve community health. We also heard from their community partners about their health priorities and were able to introduce them to NINR. So Dr. Erin Athy and colleagues from C3 Cares will be here today to share more about their work and what they're doing to improve the health of DC residents. And for us, we're really looking forward to learning more about how we can better serve, as well as collaborate with organizations in DC to advance our common health goals. Over the last year, I wanted to share that we have been developing a partnership with several universities in Southeastern Virginia called Enrich Plus. The focus is on advancing health equity and reducing health disparities in that geographic area through community engagement and team science that also helps to diversify the research workforce. So we visited these universities and community partners in August and again in January, and are now planning next steps to learn more about community research priorities. So we're looking forward to continuing those conversations and sharing more about that partnership in upcoming meetings. In March, NINR staff took part in a conference for the National Coalition of Ethnic Minority Nurse Associations. It was great to see Dr. Wang there, who is the immediate past president of the Asian American Pacific Islander Nurses Association, as well as Dr. Guillermo Ramos. So it was fun to see you in LA. This organization is made up of 5 national ethnic nurse associations, giving voice to over 350,000 ethnic nurses. And their mission is very much aligned with our own, to be the unified body advocating for equity and justice and healthcare. So we reached out about their interest in hosting a listening session at their conference because we wanted to hear from their members about their ideas for cultivating diversity in perspectives and nursing research, removing structural barriers from research, and fostering inclusion and accessibility in designing, conducting, and participating in research. So we were very pleased that NCMNA's members were very forthcoming with us. We were excited to hear about shared interest in building partnerships between community groups and research organizations, the development of mentorship and training programs for nurses of diverse backgrounds, and creating more equitable funding opportunities. So this information has already started to inform our DEIA action plan, along with feedback that we received at a similar session with AACN in the fall. I think I'm talking too much because, yeah. Okay, so in other outreach efforts related to DEIA, NINR staff members presented a poster at the Health Disparities Conference at Xavier University last month. This conference was focused on social determinants of health and was presented by the Center for Minority Health and Health Disparities Research and Education. So during the poster session, NINR was able to interact with a diverse group of researchers, including nurse scientists who either were unfamiliar with NINR or were familiar with NINR but were unaware of the new strategic plan. Attendees were excited to learn about our emphasis on health equity and social determinants of health. And last month, I visited the University of North Dakota, where I presented at an event for the university's Indigenous Trauma and Resilience Research Center. NIH awarded $10 million to develop that center in 2021. While I was there, I had a fireside chat with nursing. It was cold, so it really was a fireside. It was real cold. With nursing students, primarily undergraduates, about the importance of nursing research. I also met with nursing faculty about their research interests. The visit provided an important opportunity to connect with Indigenous groups in that area, and I was really happy to participate and represent NIH and see the work that we are supporting in this community. We've had a lot of success this year. I hope you can see identifying in lots of ways, but including identifying folks who share NINR's vision for nursing research. So wanted to just pause, check in if there are organizations or entities that you see that we could be potential partners with or collaborators with to advance the goals that we've talked about. So who should we be reaching out to? Who else should we be connecting with? Just curious if you have any immediate thoughts about that. I like to spring these things on you, right? Like, what are all your ideas? I don't know.
Shannon, I see that you connected with some minority serving and HBCUs, which I think is really smart, and I think that is an opportunity. I think we've talked about that before within this council about thinking of how to really, as we try to change the narrative, change the narrators, and find supports and ways to connect and bring along others. And I know where Daniel is, but he's doing some great work in there you are. In that space. So I think that's really important.
So I'll just add to that if that's okay. I'm actually very pleased to see that you went to Xavier University and went to their 17th annual conference. It's a conference that I've gone to year after year. So it's refreshing to see that you're making inroads with them because they really bring together a lot of the HBCUs as well as other MSIs together. I would also urge the NINR to look at the tribal colleges and make a concerted outreach there. I know that there are many Native American scholars, leaders who have approached us saying want to get involved. We're the invisible population, and yet folks often exclude us. So I think that would be another great group of folks to do. And then I just wanted to make a comment to what you presented. We're talking about who else should you reach out to, but I was extremely pleased to see the numbers, the statistics in terms of your investments in the research portfolio. Glad to see the investments in the social and behavioral sciences, connecting diseases of the brain with our systemic health. Glad to see the SDOH health disparities and minority health piece. And the reason I'm excited is because, there was a report that was done by Ernst & Young where they looked at the investments from government, philanthropy, et cetera, and found that between 2002 and 2022, we had spent about $173 billion from the government. I'm glad to see that has ratcheted up, and NINR is leading in many respects in those investments. That's a huge win for us. Dr. Guillermo Ramos and I were talking earlier about the dearth of interventions, where we are bridging clinical interventions with the social determinants of health interventions, and the dearth in terms of applying an equity lens. And so it is refreshing to know that you are building that taxonomy for us so that we can leverage those interventions in our community. So kudos to you all again for doing that. And I think the other last comment I'd make is that it's also refreshing to see the amount of publications coming out of the investments from this institute, because I've been tracking for the last 20 years too, how many publications that are in peer-reviewed journals that touch on minority health, touch on health equity, health disparities, and so forth. And year after year over the last 5 years, we've seen 7,000 peer-reviewed journal articles helping us to understand these issues better. And it seems to me that NINR is leading that as well. So again, thank you for that.
It's really difficult to speak after Professor Doss. Just three really quick things, Shannon. One, I think the report was absolutely stunning, and congratulations to everyone at the Institute, because it's clear there's been a lot of progress, and it looks like it's been a really fruitful year. So thank you for that. Two things. One is you asked about partnerships, and I really appreciate the proximity that it appears you guys are positioning yourselves to the actual communities. I wonder if there might be an additional strategy, sort of an and, not an or, where some of the large national organizations that really represent huge segments of communities that are minoritized and marginalized could become partners. So, for example, the one that I'm thinking of that I know fairly well, is just an example of one, is Unidos US, which represents hundreds and hundreds of nonprofit Latino serving organizations across the United States. In a couple of weeks, we'll be having the national conference. And there will probably be about 25,000 people there, all working on Latino health issues and Latino opportunities, economics, housing, et cetera. So organizations like that across, they are somewhat removed from the day-to-day work, but they really represent a way to have huge impact. And then I just wanted to build also on what Daniel said. Obviously your data is going to be more accurate, but I had seen some data as well that had NINR leading on some of the social determinants of health investments. And so just curious, maybe at a later time, to understanding more how you guys calculated, because I think that's really important.
So first of all, there is this thing called the Alliance of Hispanic Serving Research Universities. So there are 571 currently federally designated HSIs, but there's only 21 that are, kind of high research and have incredible capacity, and most of them have clinical enterprises. And I'm on the board of that alliance. And if you want to be introduced and explore opportunities there, I would be happy to help out with that. And it's a group that is very, very committed to the high minority student populations that they have. The other thing that occurred to me while you were talking is I prefer to call it social drivers of health, because if it were determinants, I wouldn't be a healthy adult right now, given my own, my roots, right? But that being said, on social drivers of health, so I'll use that term, on social drivers of health, this is not so much research, but it feels to me that there's so much opportunity for advancing our understanding of how social drivers affect health if we had more in the way of interprofessional education, where you were sort of looking at that team, right, of healthcare providers, which includes your nurses and your doctors and your pharmacists and your dentists and your physical therapists and occupational therapists, that whole team, nurse educators, et cetera, that surround patients. If there was some kind of interprofessional education around social drivers of health, that it was not just about how does social drivers of health affect health, but also if you were working across a healthcare team, how would you take into consideration social drivers of health to change the way that you deliver deliver care to people.
This is not a community-based suggestion, but there are also other institutes undergoing strategic plan revisions, and I have not seen those, but I'm hearing rumblings of social drivers, diversity, equity, inclusion, and so I also wonder if there's enough momentum across institutes, if it presents some opportunities for some real partnership to basically get out there and get the word out.
I also think, first, thank you for coming to NCMNA, but I also feel like sometimes we can engage with these communities and academic institutions like HBCU, Hispanic Serving, ANHPI institutions, not only kind of engaging and informing nursing science, but maybe also think about leveraging the network to disseminate kind of nurse-led nursing science from a dissemination implementation science perspective to really introduce more of the nursing science or evidence that is generated by NINR funded researchers. And can we leverage these community and academic institutions to more broadly, widely disseminating, especially we have seen a larger portfolio of NINR funded SDOH research. So think about like this partnership can really inform the full cycle of nursing science, informing health policy. I also think the Robert Johnson Foundation funded a Culture of Health program at the National Academy of Medicine. They're going to have an annual gathering this July, and then really would like to see more of the work of NINR funded work featured in this forum. I'm happy to introduce, and I know they're convening panels at this moment. I think just leveraging a lot of other organizations, be it in the health policy, and kind of try to feature nursing science, nurse or nurse practitioner led research in this area can really bring out what we have found or what needs to be done more through this larger partnership and collaborations. I'm really happy to see that you have already done a lot, but maybe can really get it to the next level of larger dissemination.
A lot of great comments, so I won't repeat them. The one related to what Anne was saying, Dr. Fitzpatrick, was the research centers at minority institutions. And it's not so much those centers themselves, but a clinical research network that's being established within that seems to be led by a lot more nursing researchers based on our last conference. And so I think the involvement of NINR in that annual conference, I think, would also bring more exposure, similar to what Professor Dawes was saying. I also really appreciated all the data, but I have some questions regarding the inclusion data. I would be curious to know, especially given the type of research that NINR is supporting, that inclusion, is that in intervention related research or is it in observational research? It's everything. Is there any way to disentangle? It'd be hard, right?
It would be a little tricky.
Yeah.
As far as I can remember, there's no NIH code to split up those areas of research. It's certainly something we could look into to at least do it informally, just on our end.
Yeah, I mean, it would definitely help bolster the argument about big clinical research in terms of involving racial ethnic minorities. The other thing is data really on organizational involvement. And so we know, using C3 as an example, that nurses can be in different contexts, and really trying to understand where those systems of care are actually occurring in these research, I think would also be really interesting to look at.
I mean, I could just react to everything you all are saying. So let's talk more, but this is great. We're keeping notes. We have the recording. So this is all good. So we'll use this to inform the agenda for next time and share more information along these lines. But yeah, let's connect one-on-one and in groups too, to talk about how to move all these great ideas. Really appreciate your support and these excellent ideas to really increase the reach of the Institute and the impact of nursing research. So thank you. Okay, so you're not done with me yet. I've got more news to share, so I'm gonna go forward, and you're gonna be interested, so I don't want you to miss. So I want to share a little bit more about some things happening at the Institute for your awareness. So most of you know the NINR Division of Extramural Science Programs oversees and manages the portfolio of grants and contracts that support researchers across the country. So since there are a number of people here that interact with that division, I wanted to share some of the changes there. So the division recently restructured into 3 branches that better reflect the strategic plan. So we did consider a wide variety, you can imagine, of different structures. For example, the creation of 5 different branches that align with the lenses in the strategic plan. But really, after a lot of discussion, there really was a strong consensus that health equity and social determinants of health cut across all of our areas. So that, and they should have the strong integration across all of our activities. So we arrived at 3 branches, the systems and models of care, prevention and health promotion, and population and community health. Again, social determinants of health and health equity will appear across all of those branches. We have 2 new branch chiefs in the division that I certainly want to recognize. Karen Kale is now the chief of the Systems and Models of Care branch, and Nadra Tyrus is the chief of the Prevention and Health Promotion branch. So Dr. Tarlov will have another hat serving as the acting chief of the Population and Community Health branch while we search for that chief. So for those who aren't familiar with Dr. Kale and Dr. Tyrus, Dr. Karen Kale joined NINR in 2014 as a program director. Her research focuses on improving care in the last phase of life using implementation and pragmatic strategies. Her clinical expertise is in pain and symptom management and palliative care, and she is especially interested in optimizing health in rural populations. She has practiced in a variety of inpatient and outpatient settings, in roles that include clinical nurse specialist and clinical nurse educator. And then Dr. Commander Nadra Tyrus recently joined NINR from the NIH Office of Strategic Coordination, where she was the program leader of the Transformative Health Disparities Program. She also led the development and implementation of the COMPASS Coordination Center and served as the evaluation SME for the NIH FIRST Coordination and Evaluation Center. She provides her 20-year expertise to NINR in areas ranging from prevention to community health to social determinants of health, including time as program director at NIMHD and a 9-year tenure at HRSA. So congratulations to Karen and to Nadra. This slide shows which branch the NINR program directors are within for this new structure. So you'll see names there, and you can also find that coming on our website. And speaking of staff, I also want to welcome some new staff since our last meeting. So first, a special welcome to Dr. Allison Colbert, who is working in the Office of the Director this year as a strategic advisor. Dr. Colbert is a professor at the University of Duquesne School of Nursing. As a clinical nurse specialist who is committed to helping the underserved, she brings 15 years of experience in settings such as jails, drug and alcohol treatment facilities, and community clinics. Nyala Johnson also joined the Office of the Director as a management analyst. We have 3 staff joining the Division of Extramural Research, Dr. Dara Blackman-Demner, Dr. Annie Laurie McCree, and as I mentioned, Dr. Nadra Tyrus. So welcome everyone. The 2 articles featured on this slide are from authors from the extramural division. The first one is about the listening sessions that NIH held to inform the development of COMPASS. As some of you know, COMPASS recognizes the essential role of community organizations as the lead in addressing persistent structural and social challenges to advance health equity. The insights gained from that listening session were used to inform the goals of COMPASS as well as some of the initiatives. So Dr. Shalonda Bynum helped to co-author that article. The other article was co-authored by Dr. Dion Godet-Greer. This is a portfolio analysis which assessed the level of funding for health and housing research from the NIH, CDC, and HUD. So as we know, housing is a major social determinant of health. Among the findings were that studies of housing affordability and stability were the least common, and only 27% of funded projects were intervention studies, pointing to the need for rigorous evaluations of housing and related policy interventions. I had the pleasure of attending the Advancing Cures Today, or ACT for NIH Foundation's 10th anniversary congressional reception at the Library of Congress on April 30th. ACT for NIH Foundation's mission is to support NIH and educate members of Congress about the return on investment from NIH research. Over 20 members of Congress attended the briefing, including House Minority Leader Hakeem Jeffries and House and Senate Appropriations leadership. I had the opportunity to meet and thank several members of the House and Senate Appropriations committees for their continued support of NIH and NINR, members who, as you know, are responsible for setting the funding levels each year. They included the chair and ranking member of the House Labor HHS Education Appropriations Subcommittee, Congressman Robert Aderholt from Alabama, who is pictured here, and Congresswoman Rosa DeLauro from Connecticut, as well as Vice Chair of the Senate Appropriations Committee, Senator Susan Collins from Maine. And I also met committee member Senator Maggie Hassan from New Hampshire. So it was great to have a chance to meet those individuals in person and to talk about the exciting work that we are doing at NINR and NIH. So continuing with the topic of appropriations, this slide outlines our appropriations history over the last few years. In March of this year, the president signed a minibus spending bill to keep NIH institutes running through September 30th. NINR ended up with a flat budget, which is actually a small cut due to inflation and the loss of purchasing power. The good news is that we retained the $10 million for health disparities research from fiscal year 23. And we did avoid more significant cuts to funding, which were unfortunately experienced by some other parts of NIH. Also in March, the president released his budget request for fiscal year 25, which for NINR essentially requested flat funding. I probably should move along. So I'm sorry, we'll have to save the discussion for later. Okay. So I'm going to turn to some updates about NIH because I don't want you to miss these. I'd like to share with you an innovative initiative NIH is considering to establish a network for research in primary care settings. So this effort is a priority for the NIH director, Dr. Bertinoli, and its initial setup is being led by the NIH OD, but it will support all ICs, including NINR. So despite our best efforts, we know that the health of the U.S. population is declining. The decline is steepest among the underserved as U.S. health disparities persist and the gaps widen. Populations traditionally underserved in research are also often medically underserved and disproportionately impacted by disease and illness. The lack of adequate representation compromises the generalizability of research outcomes and compounds health disparities. So to address this critical need to extend research participation opportunities, NIH is considering plans for a program to expand research opportunities to where people seek care by integrating clinical research in primary care settings. So NIH is launching a program to establish a primary care focused clinical research network that is disease agnostic, facilitating clinical research in mission areas across all ICs, to integrate innovative research with routine clinical care in real world settings, and to create a foundation for sustained engagement with communities underrepresented in clinical research. So NIH will hold a public half-day webinar on June 7th to discuss findings from listening sessions on how access to clinical care could be expanded through primary care settings. As I showed earlier, NINR is ahead of the curve at NIH in primary healthcare research. Primary healthcare and health services research more generally are two of the areas where NINR already stands out at NIH. Health equity is an important topic, not just for NINR, but for NIH as a whole. So I did want to draw your attention to a blog that Dr. Eliseo Perez-Estable at NIMHD and I put out on the Compass Initiative, where we shared more information about the 25 funded sites across the country that make up the heart of the Compass program. And speaking of Compass, I want to give a shout out to Council Member Dr. Suchi Ayala for her election as co-chair of the Compass Steering Committee. The Steering Committee is responsible for strategic leadership and general oversight of the Compass Consortium across all program initiatives. It is comprised of NIH Compass leadership team, as well as PIs from all three Compass initiatives, the CHESIs, the Coordination Center, and soon the research hubs. So it is great to have an NINR council member serving in that important leadership role. We're very grateful for your service, so congratulations to you. We are always looking for ways to attract new talent to the scientific research field. So one great example of this is when Dr. Bertinoli recently announced that NIH will modify its application and review process for fellowship grants. Fellowship training grants are a critical part of the development of the health research workforce. The revised approach for peer review of fellowship applications is designed to enhance participation from strong applicants at smaller schools, mentors relatively early in their careers, and well-qualified students with less conventional academic backgrounds. So Dr. Bertinoli strongly believes the changes will improve the path for talented scientists who might not be recognized under the current system. These changes will be effective for fellowship applications due on or after January 25th. So, related to attracting scientific talent, in April, NIH announced that it will raise the salaries of thousands of postdoctoral researchers and graduate students who receive NIH research fellowships. This move comes in response to recommendations from a working group that was assembled to advise on how best to retain and cultivate postdoctoral talent after reports that principal investigators were struggling to fill vacant postdoc positions. So low salaries, as you know, has also been cited as a barrier for nurses to pursue a PhD and postdoctoral positions. So I wanted to be sure to draw this change to your attention. And then we have some leadership changes at NIH that I want to share before I close. So NIH Director Dr. Monica Bertinoli named Dr. Sean Mooney as the Director of the Center for Information Technology. He started just in March. Dr. Mooney joins NIH from the University of Washington School of Medicine in Seattle. As part of that role, he also served as Chief Research Information Officer, Interim Director of the Institute for Medical Data Science, and Director of Informatics for the Institute of Translational Health Sciences. With a background in chemistry and informatics, Dr. Mooney's research interests focus on leveraging computational cyber infrastructure and data science to enable discovery within biomedical research. So welcome to him. Dr. Bertinoli also named Dr. Kathleen Newsel as the 13th Director of the Fogarty International Center and NIH Associate Director for International Research. She started at Fogarty this month. Dr. Newsel is the first woman to hold a permanent position since the inception of the center. She joins from the University of Maryland, Baltimore, where she was a professor as well as director of the Center for Vaccine Development and Global Health. She serves as a vaccine policy advisor for both CDC and the World Health Organization. And then finally, our long-term colleague, Dr. Joshua Gordon, is expected to leave the NIH and the National Institute of Mental Health on June 14th. He'll be returning to Columbia University as chair of the Department of Psychiatry and psychiatrist-in-chief of the New York Presbyterian Hospital campus. Dr. Gordon will also serve as director of the New York State Psychiatric Institute. So while a national search will be conducted for the new director, in the interim, Dr. Shelley Avenoli will serve as acting director. Okay. So as I wrap up, I want to thank all my colleagues for compiling all that data, all that information, that I was able to share with you today. I want to thank all my colleagues here at NINR and on Council for your continued support. And with that, I am pleased to introduce our first speaker. Dr. Valerie Durant joins us to review some important changes to grant review procedures. At the NIH Center for Scientific Review, Dr. Durant is the director of the Division of AIDS, Behavioral, and Population Sciences. She joined CSR in 2003 as a scientific review officer and later served as the chief of the Population Sciences and Epidemiology Integrated Review Group before taking her current position. She had previously been a program officer at the National Academy's Committee on Population, where her research focused on transitions to adulthood in developing countries, gender and health, and the health and well-being of adolescents in developing countries. So thank you for joining us today, Dr. Durant.
Great, so happy to be here. As Shannon mentioned, my main goal today is to share with you some of the upcoming changes. Hopefully you've heard about them and they won't be brand new, but we'll dig into a little bit of the specifics so that you know what's coming. Before let's kind of slides are not changing. There we go. Need to push a little harder. I don't want to belabor this too much, but just to let you know where the Center for Scientific Review is situated. We are one of the 27 broader institutes. We are not a funding institute. Our primary role is to serve, to coordinate the peer review and the first level of review that then of the applications that come to you for ultimate decisions. So we work across all of NIH. Our mission is to ensure that NIH grant applications get fair, independent expert scientific reviews free from inappropriate influences. This is the CSR mission. It is also the goal of all of NIH peer review. So there's also review that is done within each of the ICs, and most of my comments today apply across the board. So really speaking across all of NIH review, not just NIH, but our primary goal and our sole focus is on high quality scientific review of technical merit. The role we play is to assess that so that you can then take the information about the scientific and technical merit and incorporate that into your broader decisions, your budgets, your priorities, your strategic plans, the directions where you think things should be going. And then the NIH structure is intentionally set up to separate those two things to give you that information without some of those considerations. I also like to set the scope of what we do at NIH. NIH in fiscal year 23, so last year, received almost 80,000 applications. CSR reviewed 60,000 of those. We review at CSR the majority of the RO1s, the majority of the SBIR, STTR small business grants, as well as the fellowships and a range of other activities. Obviously, we do this with a lot of help. These reviews, and this is specific to the Center for Scientific Review and does not include other reviews done across NIH, but included over 1,200 meetings and 19,000 reviewers. So anything we talk about in terms of scientific review is fairly large scale, and like to just set that up as the context. So what I want to spend most of my time today talking to you about is changes that we have coming in the peer review of research project grants, as well as fellowships and the changes that Shannon mentioned earlier. So we'll dig into a little bit of each of these. So let me start with the research project grants. And you've heard about these a little bit before, so just reminding you about what is changing. So one, we currently have 5 review criteria. We are collapsing those into 3 factors. I'll get into some of the specifics in a second. We are moving 2 of those current review criteria, investigator and environment, into one of the factors and reviewing them as a binary decision of appropriate versus gaps identified. We've moved some of the additional review criteria around. These are things like human subjects considerations, inclusions considerations, to simplify and basically put them where they logically make more sense. So we're taking the opportunity to do that. And then there are also a number of other factors that have been added into the scientific peer review that are really more administrative, and those are being moved out of peer review so that the peer reviewers can focus on the scientific and technical merit. The bottom line and the justification, the motivation for all of this is really to make sure that the peer review at that first level can focus on the scientific and technical merit. We want input on what will the advances to science be, what is the potential to really make a contribution for these applications. And so the goal is to pull the reviewers back and make sure that we're framing the ask to them in a way where we will get that information. So let me step back and just, again, kind of remind you of the motivation for these changes. As I mentioned, one was that this started out primarily as a project to simplify peer review with the recognition that there were lots of different considerations being put on the plate of peer reviewers, and lots of just complexity that was potentially distracting and not fully achieving the goals at all times. We got this from lots of input from the scientific community. It's something we regularly heard from the community, from reviewers, as well as observed ourselves. And one area, as I mentioned, was there were a number of things that were being added that were really much more administrative compliance that could be better handled closer to the funding decisions and by NIH staff as opposed to peer reviewers. So again, wanted to remove everything we possibly could other than that scientific and technical merit. The second motivation of some of the changes is, alongside this was this growing awareness, concern, I guess I should say, of biases potentially slipping into review, undue influence of reputation. That is the primary bias that we do see in review and it generally comes in the form of, oh, we all know this investigator, or they come from this great institution and therefore we can trust them. I think anybody who has served on an NIH panel or at some point has heard that we can trust them phrase. And the goal with the review criterion, with our consideration of scientific and technical merit for project grants, is really to say, do we have the right expertise for the project? So again, getting back to that. I want to make sure that we are phrasing the ask to reviewers and we are getting information that focuses on whether the investigators are not just great and the environments are not just great, but whether they are appropriate for the project and will advance the ability of the project to be completed successfully. So let's get into a few of the specifics of what this looks like. So as I mentioned, we are moving to asking reviewers to focus on 3 factors. We are taking the same 5 review criteria that are part of regulation and grouping them together and asking reviewers to speak first to the importance of the research. So should the research be done is the shorthand question that we often ask. Reviewers are asked to score this on a 1 to 9 scale, as they currently do, and it incorporates an integration of the current review criteria of significance and innovation in a way that allows for more natural integration of those 2 concepts. One of the regular challenges with peer review was around innovation and how to integrate innovation, because not all science is innovative, and science doesn't have to be innovative to have an advance On the other hand, some very innovative science really should be acknowledged as having a potential high impact. And so the integration of these two into this factor, phrasing it as should the research be done or what's the importance of the research, we hope will allow us to get better input on that. The second factor is called rigor and feasibility. It pulls in the considerations that were previously are part of the approach, but really focuses on what we care about in the approach, which is, will the research be done in a rigorous way? Is it reproducible? Is it feasible? And feasible not in a way of, will it be done perfectly, but is it proposed in a way that makes logical sense and includes kind of calculated risks, so that we allow for the natural scientific process to roll out, and we don't expect perfect designs or perfect measures, everything perfect in the application level. We want to make sure we have a good solid foundation and there's a plan for how to address unexpected or lessons learned along the way. The third factor, as I mentioned, is expertise and resources. This is not scored, so the first two are get a score as well as comments. The third is the expertise and resources appropriate for the research being proposed? If it's appropriate, move on. Or gaps identified, briefly speak to what those gaps are. It's very specific to the project being proposed. The other change is related to the additional review criteria and where the inclusion plan, so consideration of the sample has been wrapped into rigor and feasibility as opposed to being kind of a box after. These have always been possible to affect the score, so they've always been considerations, but including them in two different parts of the review process raised some questions, and now it's putting it really where it fits. So asking, are the samples appropriate? Are the considerations all in place and supporting the research? In terms of the other additional criteria, these are things that can affect the score. They are not independently scored. Those will all remain intact. And then, as I mentioned, there's some other additional review criteria that did not affect the score, have never affected the score, and those have been moved out to a consideration post-review. So here's the long list. This is not every application is affected. As I mentioned, it's research project grants. The slide shows the specific activity codes that are included in this. It is the bulk of the research project grants. It excludes the small business, are not yet incorporated into this. And as mentioned, this will be effective with due dates starting January 25th, 2025. So we're coming up quickly. And there is a lot of information and available on the web, and I'll get to that in a sec. Actually, here, I'll get to that now. Here's the website. Our primary goal over the next 6 months is really socialization, making sure people are aware of these changes and know what's coming and know what is affected and the why. And that's one of the reasons I'm here, is to explain some of the why. So at this website, it's a public website. You can get lots of information that is regularly updated about the changes, what's coming, why, training materials. There's seminars, webinars that have been held, and the video recordings are there, actively maintained, frequently asked questions, and other information. So let me also turn to the changes related to the review and applications, actually, of the fellowship applications that were a parallel project. Won't go into the background of the NR National Research Service Awards, but this includes all of NIH fellowship and F awards. Similar to the research project grants, we were hearing ongoing input from the research community. Sounds like I don't need to go into that too much or familiar with that. That recognize that NIH fellowship awards were concentrated in a limited number of institutions, and that there were a lot of people that were being left out of the process. Our own data analysis supported this, and I'll just show you a little bit of that analysis. So the bulk of the fellowship applications that NIH has received come from a relatively small number of institutions. You kind of have to do the math and flip this graph, but there are 15 institutions that submit 100 or more applications. And if you put kind of the two highest submitting institution categories together, you have those group of 22 institutions submitting more than all the other institutions combined. Which there's an economy of scale here and expertise and there are a variety of factors that support that. In addition, the more applications an institution submits, the better they are. And again, it's probably the economies of scale and the knowledge and resources that they build up and can submit applications. So with the reassessment of fellowship applications, again, the goal is to really make sure that we are focusing reviewers on the right considerations, making sure they are really paying attention to the goals of the NRS program, which is to develop research careers, to make sure that we're including a broad range of researchers, not just from different institutions and different backgrounds, but also with interest in going to different research institutions and making sure that we are really keeping a broad and open goal. So our focus in the shifts and the changes that we've made in the review of the fellowship application is intended to focus reviewer attention on three key assessments. So really the quality of the candidate and their potential, their preparation and potential, the research training plan, so what they propose to do in order to gain traction as a independent researcher, and the commitment to the candidate from the sponsors, the institutions where they will be working. A second main driver, as I mentioned, is really to make sure that we are expanding the pool and bringing in the full range of potential candidates and providing a fair review across the board by reducing bias and really, again, kind of emphasizing the potential of the candidate, not the quality of the application product itself. Again, I've highlighted the three main criteria that the reviewers will be asked to speak on. The current criteria are on the left and the new ones are on the right. And what the goal is really to, again, focus on the candidate, focus on a more open assessment of the candidate that looks at the full scope of their training, their interests, what they have done to pull together their training plan, where they plan to take their research, and really focus on that and the quality of that plan in order to advance their career. The changes to the fellowship review focus required changes to the fellowship application. So we will be changing the application as well to support the review of applications. Some of that is removing some of the factors that can create the bias. Some of it is really just organizing and getting information that better aligns with the interests of the new review criteria. First change to the application is removing grades from those applications. There is a list of courses that is provided. We want to make sure we have the training, but We found that reviewers overemphasize grades and kind of navigate kind of quick indicators as opposed to digging into the quality and what people are doing and what they have achieved. And so we want to remove that. As we mentioned, there are other changes to the applicant section that really focus attention on broader considerations. We've revised the sponsor and collaborator consultants to focus on how they will specifically work with the applicant or the candidate, as opposed to just a generic statement about their qualifications. The letters of reference have been revised. This is really more to make them simpler and make them a little bit more standard, but also less boilerplate. There are no significant changes to the research training plan. So there is a research project that is a core part of the application that remains unchanged. And then there's also a section in the application to add an optional personal statement or a statement if there's any considerations about past trajectories or anything that may be relevant. Through our feedback process, as we've rolled out some of the changes and asked for input, one of the things that came up that we also have done is to clarify the instructions to make sure it's really clear which part of, whether the candidate, the institution, or the sponsor fills out which part of the application, so that there's more consistency in that. So we have done that. Timeline for implementation is the same. So these are for applications due starting January 25th, 2025, and after for the majority of the fellowship due dates, that would be in April 8th. Say for summer review and October council. And it is all of the NRSA activities. These are the primary changes coming. They do come in the context of a number of other changes. So let me just touch on those briefly. We've touched on the simplifying review framework for the research project grants and the fellowship applications. Those are by far the biggest changes coming, but there are a couple others. So one, I mentioned the changes to the reference letters. That's true for all reference letters, including Ks. So that is a standard change across all applications. Again, all of this is starting with the January 25th, 2025, the magic dates. Every few years, oh, I skipped. There's also some updates to the institutional training grants. I'm not going to go into the details on those. There is a webinar on June 5th to go through those changes. A lot of it's in the forms and just some of the supporting materials, but I did want to make sure that you were aware that there were changes coming to that. Every few years, NIH updates the forms that's used. They save up some of these little minor changes or the wording changes or the alignment changes, and this is one of those years. So there is a set of new forms coming with relatively minor changes. There will be some changes to obviously to the fellowship applications, but minor changes otherwise as well. And then another big change that is actually off this current timeline, throwing everybody through a confusion loop, is the change to we're moving towards a common form for biographical sketches. So this is to align with agencies across the government and integrate more attention and consistency in how conflicts of interest and disclosures are handled. So that will be coming in the spring of 2025, and more information is available at this website. This website really touches and goes into depth in all of these changes if you're interested in any more information about specifics of those. So before I close, I just wanted to really to come back to CSR specifically and just touch a little bit on a couple of the activities going on within CSR that are probably of most relevance to NINR. I usually don't show a CSR organizational chart when I go to advisory councils because no one cares about our internal structures. But I did want to highlight it this time. The Center for Scientific Review has 5 scientific divisions. So we just divide the applications up loosely by science and different areas. I'm over here in the Division of AIDS, Behavioral and Population Sciences. And I highlight this because we do review of the applications. So this is the investigator-initiated applications. 99% of NINR applications are reviewed within my division. So there's a very close alignment. And the other thing I wanted to let you know is a few changes that are coming to some of our study sections. So what I have here is the branches within my division. So, and part of why I show this is I'm just struck by how much alignment there is in the NINR strategic plan with what with the input we've been getting and some of the directions we've been taking. So we have 5 branches where we divide up the study sections and review applications. And this is more just to kind of give you a flavor of the scope of what we do. Within each of these 5 branches, we have multiple study sections, and we cover everything from biobehavioral processes up through bioinformatics, health services, so the full, anything human, the full scale and scope. If I overlay here the strategic plan of NINR, you can really see the level of overlap. The other thing that I wanted to mention is we have recently been going through our NINR process, which is where we evaluate our study sections and make sure that the scientific scope is remaining consistent and aligns with science in order to best identify the high quality science. We are currently in the process of doing that with a cluster of our study sections that loosely fall in the social and behavioral sciences area. And we are reorganizing several of those study sections in the next year. We have the NINR process includes an external committee where we get input on kind of helping us map on the nature of our applications with the current scientific fields and make sure that we're including we're getting kind of out of our own administrative habits and getting some fresh input. We then involve an NIH internal group to provide some input. And we have received approval to move forward with reconfiguring 9 study sections into 8 study sections that I think will ultimately become 9 study sections, but we're starting with the 8. And one of the things that I wanted to highlight is, again, kind of the alignment with the NIH or the NINR strategic plan. So we are currently, we have reconfigured study sections proposed that focus on community health. We already have a couple of community study sections, but it's refreshing and really renewing the concept of community and reflecting what community means now. We have a population level social science a study section plan that includes a lot of policy integration. Again, we have a similar study section now, but it incorporates so many of the concepts and the integration of the social drivers of health. I love that concept. And other considerations. Also, we have added a study section that will be focusing on health equity from a social and behavioral perspective. We currently have one in the health services area that has a specific health disparities focus, and there is one that is currently, at least in the feasibility testing for the social and behavioral area, primarily to look at structural drivers, systemic underpinnings. So the idea is reviewing the applications that are really trying to focus on what creates, what supports equity, inequity, on all those structural and systemic determinants across multiple levels. So it could be at the individual level, it could be at the policy or community level. So we have a few of those coming. Again, we have a process where we take these through a mock sort and make sure that they're viable. And once they're ready, we'll get information out and we'll make sure that we get that to you. I'm thrilled to see the feedback that we got from a very different kind of question that we posed to our external community, overlapping so much with what I see in your strategic plan and what I hear from your discussion. It gives me a lot of confidence that we're going in the right direction and that there is this alignment. So, oops.
That was great. Thank you so much. Yes, you got a round of applause. I never get that. Never, never. Okay, so Dr. Stone, I think is going to start us off. Pat, can you hear us?
I can hear you. Can you hear me okay?
Yes, thanks.
Oh, okay, great. Thank you, Dr. Durant. That was very, very exciting. I'm really, personally, am very pleased with these changes. I do think that, thinking about the R's, not the fellowship training grants, I do have some questions. It seems like we're going to be actually restructuring how we write them into like mainly two factors, because expertise and resources is going to be on our bio and our facilities. But so really we're going to sort of have it in two factors: importance of the research and then rigor and feasibility. Is that how you're thinking grants will be coming in after January?
There's actually no change to the form. So we're planning to have, there are no changes to the form. So the 5 review criteria now are just being combined in different ways. We always encourage people to review and to read what we call section 5, which is the review criteria in each of the NOFOs. And to think about that in terms of the preparation of the grant, that's what the reviewers are going to be looking at. But the review criteria are the same, or at least in kind of the larger categories. So we did not see any need to change the structure of the application.
Yeah, no, I mean, I don't think the application itself would change. Mm-hmm. I'm just thinking the way I organize and my headings, might very well change, as, I'll put innovation in, there'll be like, factor 1 or something, and then that's just what I was thinking, how it would be that, and will the actual review templates be out in time for the people to see? Because that's going to be important, I think.
Yes, thank you for raising that, because it was a bullet on one of my slides and I must have kind of skipped over it. Yeah, we are in the process of doing, right now, our outreach focus is just awareness of the broader changes and the why. And the next step, which we have started, is really making sure the applicant community is informed. So there's a number of webinars that we have held and that will continue to be held. Right now, we have released a little bit of information. So there is a mock new critique template for reviewers, if you're interested in that. So that is currently available. We will be building in and adding, rolling out a number of other training resources and information resources targeting the specifics of the review in the fall. So there's always a challenge and a tension with changes at NIH. We don't want to confuse people coming in now. So we want to make sure people are aware, but that will all be on that website. There's currently a section, if you go to the Simplifying Peer Review website, a pretty elaborate section on what applicants need to know. That will give you a number of considerations about writing your application and structure, the why, what to consider. And there's right now a section for reviewers. There's just nothing there yet, but it's being developed, and yes, it will all be available.
Sure. Well, thank you. And then going to the fellowship trainings, first of all, I want to thank you for taking off the grades. Thank you. Because you have a fellow that's got 1 C one time, and then it's like, I mean, it wasn't fair to the applicant. So thank you for that. The revised, and then also I did have a question about when this is going to go to Ks. Right now it's only for the Fs and the training grants, but is it going to go to Ks also? There's changes.
The likely, yes. I don't want to promise. There's nothing. It's not current. It's not something we're currently working on. But the plan is we started with the two areas with the largest number of applications and the most kind of the highest level of concerns and worked on those. So yes, but we are going to roll out the ones that we have now and then get started on the others.
In the revised sections, you have, the candidate preparedness and research training plan and commitment. I'm sure there'll be guidelines about how to do these 3 sections that'll be out. Those remind me questions that maybe other council members have some questions.
So many hands. Yes, Dr. Johnson.
Hi, Mallory Johnson. So thank you for this. This was, it's exciting to see this come out. I've been doing this long enough to have seen a number of big changes, so including the changing in the scoring system and then the reduction in the length of the applications over the years. And so there's always this period of rollout, and no matter how much planning is done, there's some bumpiness. One of the things I'm wondering about is, can you speak to what kind of training reviewers are getting so that they don't slip back into their old ways and so that they are, more oriented and actually adhering to these new concepts and guidance? And also in the interim, presumably there's still an overall impact. Is that just going to be percentiled against the older ones? And like in the interim, are they going to be compared only to each other using the new system? Or is it going to be, as it always require 3 meetings or the sort of the denominator pool? But I guess more importantly, how are we going to make sure reviewers are on board and doing this?
Yeah, great question. So we are currently rolling out very extensive training to our staff, including yesterday. We had a big training on the concepts and the why. We always like to start with the why. If people understand the why, you can usually work through those bumps a little easier. We spend a tremendous amount of time, and the reason I start with the staff is because we do spend a tremendous amount of time working with the reviewers in small groups and one-on-one. So there will be extensive training materials, guidance for reviewers that will be rolled out. But the traction that you are talking about comes from the SRO working with the reviewers once they're actually reviewing applications and reviewing in meetings. We do a number of different steps to look for alignment between scores and concepts. We have ways to look for whether we look for whether there are comments that suggest that people are including factors that are not part of the review criteria. That could include everything from information that is not presented in the application, but may be known by some people in the community and not others. It could be indicators of bias. So we do we do a lot of reviewing the critiques, providing guidance, providing conversations. We have extensive chair training that we will roll out this summer with a specific, that we do the general chair training, but we will include, we will have a specific chair training for this as well to make sure that they're partners in this. I can't remember what your second question is. Percentiling. So there'll be no changes. So the applications will all still get that overall impact score. The overall impact score will now, there's no formula of how you take the factors or right now the review criteria into that overall impact score. There's a logic, there's ranges. So now that overall impact score will be affected by 2 factors as well as the expertise and resources that can affect that, especially if there are gaps, as well as some of these other considerations. But it will primarily be be driven, assuming that they have the appropriate expertise and resources. We really want the quality, the importance of the research and the rigor and feasibility to be driving those scores. So that's the idea, and that's what we'll be looking for with our reviewers.
Yeah, I just want to applaud this. This is really exciting. And to piggyback on what Dr. Johnson was saying, I was going to talk about the same thing around, got to train reviewers around this. But I want to underscore the piece that you brought up around the rigor and feasibility. In particular, as we scale up more research that really focuses on reducing and eliminating social drivers of health. That means it's the thinking about rigor and reproducibility is going to be a lot more difficult, right? And I like what you said about does it include, there's going to be a calculated risk being taken. It's going to be more complex in a lot of ways, and having reviewers have that in mind, that for research that really tries to get at eliminating social drivers of health means it's going to be, there are going to be more risks involved, and just to understand that and take that into consideration, I think would be a big part of that training, right, of reviewers, to really think differently about that.
Yeah, there's a real emphasis in, kind of between the lines here on more big picture thinking, and making sure that we're trying to keep reviewers at a level. And in fact, we often tell them, you are their audience of the reviewers' critiques. Explain to a educated group of people that will be making funding decisions what the contribution of this application will be, and what the main driving strengths and weaknesses are, so that they can you can make informed decisions. And that's the goal of the changes in the wording, the changes in the factors, and really kind of underlying the training of how we're trying to work with reviewers, pulling them out of the weeds. It's easier to get into the weeds. It's easy to pick apart the approach. It's harder to say, what will the advance be? And so the wording in the rigor and feasibility section tries to pull that out, and it tries, we phrase it in ways that, focus on assess the design of the research. Is the design sound, or the broader goals sound. So do our best.
Yeah, I was going to comment that really, since it was initiated, reviewers have confused significance and innovation. It's very confusing. The scores are often flip-flop, like they're not at all how the instructions state to score. So I think I really like phrasing it as importance. I think that just makes sense and resonates. I think for CSR, when they clarify to reviewers, is it the importance of the approach, or is it the importance of the clinical problem? And I think this is where reviewers can still struggle semantically. I mean, you can have a population that's dying, and reviewers may not like the approach, and they say, oh, this is not important, but it's important because people are dying. And we probably all had that experience. So just my advice is to be really, really clear what's important. What do you mean by important?
Absolutely. And I would actually even kind of go a step further, and what we are asking for is the importance of the research question as proposed. So yes, it certainly incorporates the clinical or other the situation that's being investigated, but that's not all, right? We've got a lot of applications on cancer. What will this one do to advance our understanding? And so it's really trying to pull the evaluation of the importance to how will this research project advance the field. So yes, incorporating whether it addresses a gap, what the importance of the topic is, but also we don't want them to stop there. That does not provide a lot of value to say yet again that many of these situations that we already know are problems are a problem without saying how will this application advance it. So again, some of it is the specificity. Appreciate the comments on the I heard some of the changes described as a plain language effort, and your comments reinforce that. So happy to hear that.
So thank you very much for a very helpful and clear presentation. It's not that often that I think I would say I really enjoyed, I was fascinated and captivated by a presentation on something like how we're going to change review criteria. So thank you for whatever magic you carry in you.
This is recorded, right?
Yeah. Tell me who your boss is. Tell me who your boss is. I'll send an email. Here's so I'll give the caveat that I haven't served on study section in a few years, so maybe everything has changed. I do have the reviews of my own grants, and the reviews of the grants of my many mentees, which suggests to me that maybe this factor has not changed since I've been on study section, which is, I think all of these changes are needed and really good and improve, have the potential to improve. But my observation on study section is you need to have you need to have certain people on the study section who will lift everybody's sights up to the horizon. And we're increasingly getting to the stage that the people who are most capable of doing that say, I'm too busy to review. And it was constantly amazing to me how you'd have a review that was nitpicking all the way in the weeds. And that's almost like personality type. You can change the review criteria, and maybe they'll only go 60% into the weeds instead of 150% into the weeds. But I think and I don't know if there's room in the chairs of these committees to give particular consideration of, are these people who are like horizon site lifters, and can we train them to be more active in that conversation, or whether we think strategically about, on this study section, I need to make sure I have a few of these horizon lifters, because if they're there, the review, the whole room changes, especially if they're able to offer their comments in a positive, those people who are just really good in a room at managing things. I remember constantly on study section having to remind people, this is an R21. And I felt like that was my role on study section, was this is an R21. Here's what the expectations are for an R21. So I applaud you for these changes. There may be need for some parallel things to be happening in terms of staffing, selection of people on study sections.
Yep. No, really appreciate those comments. And this is one piece of a many multifaceted effort, not just related to this project, but in general. Who is at the table is critically important, and we are always looking. I love your concepts, the horizon lifters. We also work to help. This is one example of how we're trying to help other people get to that horizon level as well. So that, and there are other strategies we have to do that. We are working with the chairs. We work with our staff actually to be horizon lifters, not for the science, but for some of those other considerations if things are getting too weedy, if things are kind of spinning off into we're talking about interesting science or we're not talking about the application anymore. Some of this is done behind the scenes with the critique. Some of this is done in the meeting, but there's multiple angles with that goal. So yes, and please encourage those horizon lifters to engage in.
Just really quick comment. First, just want to say thank you very much. That was fantastic. I agree with what everyone has said. All of the changes that are coming are for the betterment of, the review process. And so thank you for that. I think it's a little nuanced, but I think you said this, Dr. Durant, but I want to highlight one piece that is really important to me. And all of these changes are not just about broadening the number of institutions or dealing with bias, but in doing that, the result is that it helps us to better eliminate inequities in our country, and it elevates the scientific work that we're doing through NIH. And I think that's the horizon lifter that doesn't rely on people, but relies on a more clear message that will allow the review committees to understand what really matters. And I think that's not really what I heard so clearly. I heard all these other great reasons, but to me, that last slide is like the first slide.
Great discussion. So Dr. Durant, thank you so much. Hopefully we can convince Dr. Durant to come back because we clearly like to engage with her. I'd say being at NIH, I've been really impressed with CSR, your constant efforts to improve review and attention to fairness. And so I want to thank you and everyone at CSR for all your work and for joining us today. So thank you. So with that, we are going to take a 15-minute break. Someone help me with the math. Is that like 24 or something? So 24, we'll see you then. Thank you. Right, welcome back from break. So we have one more agenda item before we go to lunch. So we're going to hear from Dr. John Grayson, who is director of the NINR Division of Science Policy and Public Liaison, who is going to be sharing information on our health disparities portfolio and the impact of recent RCDC changes, which he'll tell you all about. So, John.
Yes, I'll tell everyone about that in gory detail, especially knowing that I'm the only thing between you and lunch. So I'll do and I know we're running a little bit behind schedule, so I might speed up through a few of these things. But thanks for the opportunity to speak to all of you today about some recent changes in how NIH is categorizing health disparities research. And there's a few reasons we wanted to discuss this topic today. Obviously, health disparities research has been long been an important topic of interest for NIH. And that's certainly been the case at NINR, and that's only more true over the past several years. At the NIH as a whole, there was a sense that we needed to do a better job of how we track and assess the health disparities research that we currently support to allow us, better tools to analyze our current research and plan for future activities. And so that's led to this major change over just in the past year into how NIH has thought about coding and categorizing health disparities research. And the big question for all of us here today is how have those changes impacted NINR? And it's particularly important for us because, as you're all aware, in fiscal 23, Congress appropriated an additional $10 million to us specifically for health disparities research. And because we're very interested in doing what Congress tells us to do, we needed to be able to have a good handle on how much health disparities research we were supporting. So very quick history of coding and reporting at NIH, which I'm sure everyone cares about. So obviously NIH funds tens of thousands of grants every year, and we get asked all the time, how much money are you spending on X? And we get asked that by Congress, by interest groups, the public. They want an accurate answer. That's not always easy. So when I first started at NIH a few years ago, all of that coding and reporting was done manually. So it was people like me sitting in a computer looking through abstracts saying, yep, no. that sort of thing. We tried to be standardized, but in reality, everyone coded a little bit differently. All the institutes coded differently, and we ended up with numbers we ended up with dollar figures. Were they accurate? I don't know, maybe. And were they reproducible? Absolutely not. So that led to a lot of frustration, very understandable frustration from people in the community. And Congress stepped in and insisted that NIH come up with a better way of doing things. And that's what led to the RCDC system, which did away with all that manual coding with a couple of very important exceptions. So RCDC stands for Research Condition and Disease Categorization, and I'll definitely give you the abbreviated version here of how this all works. RCDC is used to report publicly how much NIH is spending in several hundred different categories of disease conditions and research areas, and it's a text mining based tool. It's designed to, the initial intent of it was designed to get rid of all those differences across the institutes in how the institutes coded and reported on their research activities, and make sure that we were all using this. And basically we had no choice. There was only one methodology then going forward. So at least it was reproducible. Was it accurate? At first, a lot of us were, including me, were very skeptical that this would work, especially because as the person coding and reporting, I had a vested interest in keeping my job. But like a lot of people, I think I came around eventually, and it really has been an outstanding tool. So very basically, the way it works is it will take the abstract, the specific aims, and the title of every application that comes into NIH and extracts a long list of words from it, and weights the words based on how frequently they appear. And there's this whole text mining algorithm that I don't understand and I'm not going to get into. It compares that long list of words against a list of terms that are put together for each of the disease areas and research areas. That's called an RCDC fingerprint. And those terms are all weighted, and those are developed by experts at NIH who are experts in each of those areas. And basically it compares the two lists of words, and through an algorithm and all sorts of matching scores and category weights, and I don't know, I'm not going to get into it because I don't really understand it completely. It determines, yes, this project is in this area, no, this project isn't in this area. It's not 100% accurate, obviously, but it does a surprisingly good job when every now and then you do an audit of the different categories, and actually once a year, all the project lists are looked through and to see how well the system is doing, and it actually does a really good job. And if you're wondering what happens to all those numbers, for those of you that haven't already, but I'm sure many of you are familiar with this, the NIH report website, report.nih.gov, all of those numbers are reported publicly for, again, 300 plus disease areas. And all that data is available to download. Yeah, definitely check it out. Lots of good information there. But how is this related to health disparities? Well, I mentioned that there were a few categories that RCDC hadn't coded, and health disparities and minority health were two of those categories. And that was an issue for us because, of course, those are two of the most important categories that we care about, and that many of the institutes at NIH care about. And so just again, a really brief history. Prior to 2016, that was all manually coded. Even after RCDC came into effect, it was still all manual coding. And it was based on this formula that where you would look at the proposed inclusion table in grant applications, And based on that, there was a whole formula thing that I won't go into, but we tried as best as we could to stick to that formula. It was not consistently applied across all the institutes. And so there was a lot of criticism of NIH for where exactly these numbers were coming from. And they moved to sort of a hybrid system back in 2016. But in 2023, the numbers that you'll see on the report website are completely coded in an automated way now by RCDC, which was a great development. But we also were somewhat concerned about, well, what is, and first thing I should say, so that there's some obvious benefits to the automated coding: accuracy, transparency, consistent definitions across the NIH. You eliminate or at least minimize the bias of the coders, better reporting, better analysis, and it also, because RCDC codes not only funded applications but also unfunded applications, on our end, it allows us to better track the work that's coming in. You can't do that for, I forget what Valerie said before, there were, just CSR alone has 80-some thousand applications. It's tough to do that by hand. So it's great having the automated system available. And the new coding structure, and I'll get to it in a minute, can better distinguish between our research efforts and also our efforts at DEIA-related initiatives and workforce development efforts. So the change that happened over the past year, in addition to moving into the automated coding, is what was 2 categories, health disparities and minority health research, is now 5 categories, and with different definitions than what we've used before that I'll get into in a minute. So we now have health disparities research. Minority health became racial and ethnic minority health research with a very different definition. Then there's essentially the combination of those 2 categories. But now there's also a separate category for workforce diversity and outreach, and building research capacity at institutions with limited NIH funding. So the definitions, health disparities research, and I'll go over these because it's important to know what these were essentially the definitions that were used by the RCDC people and by the experts that were advising those committees. These are the definitions that they used in developing those new fingerprints used by the system. So health disparities research, investigating preventable differences in health outcomes that adversely affect disadvantaged groups or communities, and research determining how this knowledge is translated into interventions to reduce disparities. And for the new minority health category, racial and ethnic minority health research, the scientific investigation of distinctive health characteristics and attributes of minority, racial, ethnic groups, including multiracial individuals. And importantly, the awards that simply stratify data by race and ethnicity are no longer included in that category. But how did this all impact us? And remember, we had the additional money, $10 million from Congress, come in. We would hope that that increase would be reflected in our reporting numbers. And mainly, we want to make sure that our institute is receiving credit for the work we're doing. So let's see how we did. So this is the history of what our health disparities numbers looked like between 2018 and 2022. So again, these were, for the most part, manual coding. And for the most part, we were, we saw a slow but steady increase. But here's what it is for 23. And we were obviously very happy to see this. This was the coding done by this new automated method that we had no control over. We wanted to just had to wait and see how much the system told us we were spending. And we were pleasantly surprised to see that under the new coding rules, our research dollar figure rose about 50%. So some of that obviously is attributable to the $10 million influx of funds. Some of it was probably because under the old coding system, we were, selling ourselves short when it came to coding. But I mean, I think it's safe to say that a good deal of the reason behind this increase is simply the work that this institute's been doing over the past several years to really, put more of an emphasis on our research in health disparities. I should point out at this point that we're really not supposed to do charts like this and compare the old days to the new days because they're not comparable. They're completely different methodologies. So with that said, let's keep comparing. Or we could just look at two data sets side by side, whatever. So this is so before this year with the manual coding, we actually we did rank second at NIH in terms of percent of budget spent on health disparities. Under the new system, that's even higher now. We're now up to about 46%, and I think that number was in Shannon's slide earlier today. We're still in second place behind NIMHD, which I think you could expect that. This is that new minority health category, racial and ethnic minority health research. And under the new coding, we're pretty much the same, though again, they're even less comparable with this definition because it's so different from the old one, and the DEIA initiatives are now moved to a new coding. So the slight decrease here isn't surprising. In fact, most of the institutes actually showed quite a bit more of a decrease. So I think this again is good news for us. And similarly, we were second place before. We're still second place when it comes to this category. But for the rest of the talk, I'll focus on the health disparities category. So if you look at if we're talking now about the number of projects we supported in FY23, just a little over half of them were categorized under the new coding as health disparities research. And the other half were not coded health disparities. If we, and I'll move really quickly through this because I'm running out of time, but if we look at a breakdown of the mechanism or the types of grants and compare between our non-HD projects and HD projects, it's more or less the same. The research projects are a little bit higher in the health disparities projects. We're still, the other thing I should say is these data came out just a few weeks ago when they were supposed to have been out back in February or something like that. So we're still trying to figure out some of the meaning behind this, but I'll report it to you today just to be thorough. If you look at the research, the RPGs, this is the breakdown of mechanisms. There's slightly more RO ones, but it's basically the same. Comparing health disparities projects to non-health disparities. At institution type, again, it's more or less the same. The higher education organizations are a little higher with the health disparities projects. And if we look at how the data for new and early stage investigators, so last year about 22% of our investigators were new investigators, according to the NIH definition. And within those new investigators, about half of them were working on projects that were coded health disparities research, and half of them weren't. And it was very similar with early stage investigators as well, about half. So the bottom line, what did we learn from this new research coding? So again, it established that we're one of the leaders at NIH in health disparities funding, minority health funding, again, as a percent of budget. We're one of the few ICs that ended up showing an increase in health disparities funding under the new coding methodology, and that reflects our strategic plan. It's a testament to the commitment of the nursing scientists that apply to us. That this has been and continues to be a focus for our investigators. We were very pleased to see that that it's reflected in the new data. Not entirely surprised, because we've put so much of an emphasis on our lenses of health equity and social determinants of health. And also we were, happy to be able to demonstrate that $10 million that we received from Congress has been put to good use, and that our efforts are reflected in the data. So I think that's my last slide. Yeah. So happy to take any questions, and thank you for your attention. Sorry if I had to rush through some of that, but we're all hungry.
Thank you, John. So we're going to pair up Dr. Beckemeyer and Dr. Grayson again. So Dr. Beckemeyer, start.
So thanks, John. I loved seeing these slides. And it gives me great pleasure to see the impressive role of NINR in not just achieving what we'd hoped to achieve with our strategic plan, and that we're seeing, these metrics really demonstrate that, but that it really shows that NINR is a leader within across the institutes as well. So that's super exciting to see. There are some things that another thing that really jumped out at me with your presentation was around the early stage investigators and the new investigators, that they are really critical to this process. They're driving in some respects a lot of these proposals. They're the bulk of these proposals, which suggests that we're on the right track, that it's going to be the new scientists and that perpetuate our field that are really going to grow this area. So that to me is really exciting, which also sort of in some respects gets back to making sure we have reviewers in place that can effectively, because they're going to be less likely perhaps to be the reviewers, right? So we have to have reviewers in place that can review these kinds of proposals, et cetera. A couple of things jumped out at me. Maybe this is too in the weeds around the data, but there was a smaller proportion of R21s than of course there's more R01s, but why would there be a smaller increase or no increase? I can't remember, in the R21s versus the R01s, when the R21s would be the precursors to the other. Anyway, maybe that's not that important of a question if the data aren't able to talk about that. But anyway, in terms of what you're talking about here, it also says to me, what is our role with the broader NIH as leaders in this space, and based on these metrics, and how do we assure that kind of influence? And also your point, John, that you made at the beginning, that we're now able to have the same data for proposals not funded. I think about what are some other analyses that could be done here, and could we also be looking at what's the nature or characteristics of proposals and maybe even individuals that aren't being funded, and are there any systematic biases or what have you we need to be taking into account? Those are just some immediate reflections.
Yeah, I think it's safe to say that with this kind of data now available NIH wide, and now that we have, some assurance that, looking at grants that come into other institutes and comparing what the different institutes are doing, that we now have a good idea that those data are, a lot more useful than they used to be. And we've already had many discussions about many different things we could look at, particularly with unfunded grants, but even with the grants that we fund now. Despite the fact that I'm not manually coding grants anymore, there's still more than enough work to keep me employed. So it was excellent news. But yeah, it's the sky's the limit at this point. This has been a very positive development.
So Dr. Grayson, John, thank you. That was a fantastic presentation. I think the news and sort of the bottom line message is just such a positive one. My comment is more about sort of two things. One, how can we better tell that story of how NINR has been a leader, whether it be the manual data or the new automated system, but it's something that we should be all collectively very proud of. And it sounds like either way, there's evidence that NINR has been certainly leading. It's second. It's second. And I think the other part is, and assuming that that message is out there in the universe, then why does it matter that NINR is doing work around, I would say, health inequities, but health disparities using the definition that is currently the definition? Because I think there's something very unique about that also has to do with the story and the institute and elevating sort of the nursing and workforce. So I'm sure that makes sense, but I guess it saddens me a bit, to be perfectly candid. I don't think the broader public understands that this has been part of NINR for so long.
And I actually have a piggyback comment to Vincent's comment that it's so amazing to see, NINR is leading the health disparities research. I'm not suggesting it, but it would be interesting since it's automatic. What do you think, Dr. Grayson, in terms of if we use a new methodology to code the couple of previous years? What do you think? Is there any kind of newer story that we can tell? If it's too, labor intensive, I'm not suggesting it, but I'm just curious if you have any kind of assumptions based on your experience manually or automatically coding this. And my second comment is, it's great to kind of have this insights based on the data that you have shared. But how do we even move forward then, not only talking or articulating the story with the broader community, but to drive the actions that NINR is leading and doing an amazing job in funding and supporting health equity, health disparities research. When there are funding opportunities out there, how can we use this story to drive more funding toward NINR to do this, because NINR has been doing this very well. So I'll end here, and I'm curious about your thoughts on kind of the application of new methodology on the past years, and is there anything else that we can add to this?
Yeah, it's something that we've started to take a look at. There's a number of technical reasons, or so I'm told, that it's not as straightforward as you might think it would be to look at previous years. I'm not entirely sure why. I think we can at least get a rough idea of how that would look, and we can certainly work with our colleagues at NIH to figure out a good way to do that. But I'm sure that that will be a very frequent question asked of NIH in the coming weeks and months now that this is out. And this is a week and a half old, I think, that this has actually been publicly released. And I wouldn't be surprised if a lot of folks get those questions. So they've made a very concerted effort to separate the before times from the new era. Like I think if you look on the report website, the data from previous years isn't featured on the website anymore. It's still available. There's a footnote. There's an email address you can get it from, but they want to make very clear that this is completely new at this point. So, but we'll see.
Yeah, I just want to add a small comment. It's like, I think the story that I'm looking for is that nurses have been doing this foundational work in the area of health equity, just like when we were at NCMNA from the very beginning, when health equity or health disparity is becoming a buzzword in the society, that we can demonstrate nurses' leading role and foundational role in this research, and to use that story to support or advocate for more funding for NINR. Thanks.
So I have a question about how the categories show up in NIH Reporter. Do they show up in NIH spending category or in project terms, or is the category a derivative of the terms?
So if you look at Reporter, there's a tab called categorical spending, I think. I'm
thinking about at the individual project level.
Yes.
Not the categorical spending, but that's an aggregate of all of the things that come up from the automated search, correct?
Correct.
So if I'm an investigator, I'm looking at a project at the moment, and there is one of the things you get is NIH spending category, and the other is project terms. So how's the automated system putting things in those buckets in the categorical spending? Is it by the spending category or the project terms, or both?
It's based on the terms. It's whatever the text mining tool that they use. However, that extracts terms and certain frequencies and at certain weights. And I think they're still looking specifically at titles and abstracts and specific games. And it generates that list of terms, which it compares those to those other lists of terms, those fingerprints that I mentioned, and sees how well they match. But it's all based on the terms that are extracted.
And then I guess my question then is, like the project that I'm looking at, the title is Hispanic Sexual Minority Youth and Their Families, but the terms are Hispanic and not Hispanic or Latino. So
right.
It seems like will there be an evaluation of how well the automated system is really capturing? Because I think that this really is important, and NINR is leading in this area. And yes, we're getting good credit, but is there maybe more traction that we need in terms of the way that the automatic system, what will be the evaluation of the automatic system going forward to make sure that it reflects the general coding that a human brain would put in place?
Yeah, and so like this, these new categories, like most of the categories, but I think, these new categories will be even more closely looked at. On an annual basis, they send us the project lists before they, essentially before they come out, months and months before they come out. And we can look through those and say, okay, these more or less look correct, or, there's a problem here. Why would the system, add that? The classic example back in the day was there were an abnormal amount of grants that were somehow coded Tampa Bay as being from Tampa Bay. It turns out they were tuberculosis grants, TB. Now that's way back in time. They fixed that sort of thing a long time ago, but
it does sort of prove the concept that if you're not paying attention, you can get
right. And it's improved so much over the years in its ability to kind of filter that stuff out. But staff does take a look at it on an annual basis and see how well it's doing. And then every few years, they do a more extensive revisit where they go back to that list of terms that was developed to make sure that it's keeping up with the science. and that it's capturing what it should. So, and like I said, I'm sure there will be extra scrutiny of these categories while they're still pretty new.
And is there any way for individual investigators to know which bucket their work has been placed in? Because no one would want to game the system, but
Right.
People would want their work to be in the bucket that they believe is most appropriate for them. And if there are terms that throw them out or into those buckets, they might want to adjust the way in which they're presenting the work.
Yeah, I would be lying if I said that I'm sure there is some gaming of the system going on.
I don't want it to be gamed, but
No, I know.
it's accurately reflecting what the work is.
Right.
And so if you're doing a Hispanic sexual minority youth project and it gets coded as both Hispanic and not Hispanic,
right.
As
And
an investigator, I would want to have some ability to say, what bucket did you actually put me in? And
right.
is there any way that I can advocate for either this project being reclassified, or is there something that I'm doing wrong in the way that I'm presenting the project to the text miner?
Yeah.
For that example, I wonder, is it possible that, so maybe part of that project you interviewed providers, like 5 providers who may or may not be Hispanic. And so if it gets, because I could see that, and then it just looks at.
But then is it
anything.
not health disparities?
Exactly.
Work?
Right. Exactly. Yeah.
Yeah. Just something to think about. What's the process for kind of back checking, both on an individual project level,
right,
which is sort of overwhelming,
yeah,
but also on the evaluation plan for the way that the system is automating.
Yeah, so you're right. On an individual project level, it's a little tricky, and we only have like a very limited ability to point out problems with individual projects. And really what we look at is whether or not a particular project gets included in a certain RCDC category. So something like Hispanic, that's not I don't think that's like a publicly reported category. And so it's just one of many terms that would factor into a category like health disparities or minority health. So, on an individual basis, if you're just looking at individual terms, that can be a little tricky because it's all based on that text mining stuff that I don't claim to understand. But there's a lot of factors that go into whether or not something is ultimately reported in a certain category, a certain RCDC category, versus whether it just has individual terms associated with it. I completely get it. It's still somewhat of a messy process just because of the ways these things work. You're right, having both of those codes there doesn't make a whole lot of sense. The hope would be that in the end, is the project itself included in the larger RCDC category or isn't it? So.
Thank you for the presentation. I have a comment that is less related to the coding and more related to Dr. Guillermo Ramos's question of why does it matter that we're leading in health disparities. And I'll offer the caveat that I'm not the dean of a college of nursing. I do have a dean of college of nursing that I work with very closely. It strikes me that there may be a story, this is really for Shannon and Elizabeth, there may be a story to tell about NINR leading in health disparities research that could help with the faculty pipeline issue and also recruitment into nursing training programs. So this sort of elevated, people like to be inspired, this elevated idea that if you care about health disparities, then there are these careers in health disparities research. And in the field of nursing, the National Institute is putting, fundamental focus on this. I just wonder whether there's some type of a story to be telling, and maybe like when all the College of Nursing deans, I'm looking at my new dean friend that I've met, when all the College of Nursing deans get together to come up with a narrative around that to help with this faculty pipeline issue. Just a thought.
This has been really helpful to me and to us. So thank you for these ideas and this support. I mean, I think this is a well-kept secret, unfortunately, of, nursing's well-established commitment to social justice, to reducing health disparities, to advancing health equity. It's long been a commitment of the Institute, and we're only amplifying on that strength in response to the critical issues that we as a nation face. So we're proud of this work. We appreciate your support, and we look forward to growing the evidence base with all of you and with the nursing community. We do want to stop being a well-kept secret. Absolutely right.
You have these great numbers to tell that story, and I just trying to figure out whatever your storytelling, your media campaign, your communication with colleges of nursing around that. That if you care about health disparities, nursing is a great place to be a faculty member, and is a great place to train as even as a bachelor's of science in nursing.
Absolutely. No, I love that idea. And you're right. We need to do better in our messaging and getting the word out. And because that will ultimately, increase the impact of the science that we're producing and bring about the changes that are needed. So we appreciate these initial ideas. We'd love to come back with, to you to get more ideas, right, about what those messages should look like. What are the audiences we should be reaching? And so I agree, it's critically important. So appreciate these initial ideas, and we'll do our homework and come back and talk more in September. We have these great data now to help John stay employed. We'll do some more analysis, keep him busy, keep him employed over the next several months. So, and we'll bring that back. Okay, so thank you for hanging in. I know we're running a little bit late, so we're going to break for lunch. We'll do 30 minutes, so that'll take us to 12:37 Eastern, and look forward to, did I mess that up again? Oh, I know, I'm very precise. Yeah, 37. So no, we'll see you around 37. Okay, thank you. All right. As we're getting together after lunch, welcome back, everyone. All right, so we're going to change our agenda, flip a couple of items, because we want to make sure our partners from DC have a chance to share with us. So we will next welcome Dr. Erin Athey, who will tell us about her experience with C3 Care's community clinic program that she founded. So Dr. Athey is a board-certified family nurse practitioner who has spent nearly 2 decades working on the east side of DC as a clinician, educator, and community engaged scholar to improve health outcomes for those who are under-resourced. Dr. Athey's experiences as a clinician led her to develop several innovative community-based initiatives that focus on improving health literacy and bringing healthcare into DC wards 5, 6, 7, and 8. These experiences, combined with her desire to improve access to care, inspired her to create C3 Cares. So Dr. Athey is joined by several of her partners today, including Keith Pettigrew of the DC Housing Authority, and Karen Dale, a nurse who is also president of AmeriHealth Caritas DC, who will also share. So before Dr. Athey begins, I'd like to ask everyone from C3 Cares and partner organizations to stand and be acknowledged. Thank you for joining us today. So, yeah, welcome. Good to see you again. Dr. Athey, the floor is yours when you're ready.
I'm just going to get started by telling you a story sort of my journey.
Dr. Athy, hold on just a sec.
Can you hear me now? Okay, perfect. Let me start again. So good afternoon, everyone. Thank you so much for having me, Director Zank. I really appreciate it, and I really appreciate my partners coming today to hear the presentation. I'm going to tell you a little bit about my journey with C3 Cares. So let's go. Let's see if I can get this going. First of all, I just want to give you a little bit of background on me. So there was a nice introduction, but I think it's important to know sort of where I've come from. I've been a nurse for 26 years now. I spent 1 year as a hospital nurse and decided that I didn't like nursing, decided that I was in the hospital with chronically ill patients, and it was very sad to me to see that these were preventable diseases that were so far gone, and I felt very disheartened. And so, you know, I considered leaving nursing, but then I immediately found community health nursing and public health nursing, and I found my love for that. And so the rest of my career, the last 25 years, I've spent as a community public health nurse. I've also been a nurse practitioner for 20 years. So I went back and became a family nurse practitioner and continued my work in community clinics. I joined the first cohort of the DNP program at the University of Virginia when they first opened it up, because I thought, well, this is a good idea. Let me learn some more how to implement projects and programs in the community. I've done a couple different programs through local hospitals, running a mobile clinic, and been faculty at GW for about 12 years now. I've also, you know, been teaching nursing students, public health students, and now we have business students that are coming out to do community work. So it's been really exciting. In terms of my scholarship, it's really been mostly out in the community for the last 6 or 7 years. And I'll tell you a little bit more about that. And then in terms of innovation, I've done probably the 2 biggest projects are the mental health literacy program and this program that became C3 Cares that I'll tell you more about. So this is what I've learned. So I've spent almost 20 years of my career in Washington, D.C. And if you can see from the map, and I'm sure most of you have seen images similar, it's very segregated in Washington, D.C. And the health disparities follow the map of where people live and the division in the city. I learned pretty early on that zip code was more important than your genetic code. And we know this because if you live near the White House in Northwest Washington, D.C., your life expectancy is 20 years more than if you live in Ward 8, which is 3 miles away. I also learned that we have a very outdated and inconvenient model of healthcare. So working in a lot of the outpatient clinics, and the majority of my time was in an outpatient clinic in a safety net, the only safety net hospital in Washington, D.C., it wasn't convenient for folks to come in 9 to 5 when they have childcare issues, transportation issues. So it was very frustrating to me. In terms of primary care, it's fragmented and not coordinated. So a lot of folks jump from place to place. They get their primary care here today. They go somewhere else tomorrow. They use emergency room for primary care issues. And so that is a challenge. And then also in DC, they do a community health needs assessment. It's a consortium of hospitals and some federally qualified health centers, and they look at the data and they say, what are the issues in DC? And so for the last couple iterations, it's been the need for place-based care, mental health services, which are now more than ever, obviously after COVID, care coordination and navigation, which really kind of addresses this issue of the fragmentation, and health literacy. And so when we say health literacy, this is really the ability to understand, comprehend, interpret health information and make decisions about that. And I think it's interesting because there's just new data that shows that about 17% of Americans actually have high health literacy. So we know in populations that are under-resourced, that's much lower. So I like to tell people access to care is some of the issue. So we talk a lot about access to care, and to me that is more of a system issue of, are there providers? Are there enough primary care providers? Are there enough mental health providers? Are there hospitals? Are there clinics? And I think that is a big issue, but what I see more and what my experience has been is this engagement of care. And that really is about behavior. It's about, if I have a primary care provider, do I go and see them? Do I stay engaged in my care? Do I understand, what to do for my health? And I think that is more of the issue as I see it. And then in terms of healthcare industry challenges, these are probably no surprise to anyone, but the costs are reaching unsustainable levels. Care is delivered in hospitals in high cost settings. It's provided by the highest cost providers, specialists, and hospital providers. And really, quality healthcare can be delivered in many settings, right? It doesn't have to be within the white walls of a hospital. Telemedicine, we know, is a great channel. There's other community channels, local organizations, community-based organizations, and using navigators, community health workers, counselors, and et cetera. So the way that I see my little journey out into the community is using this design thinking approach. It's kind of like the plan, do, test, whatever cycle that those cycles are. So I really like to start here. This was kind of an inflection point for me, standing in the hospital clinic, just sort of thinking about how I can better serve my patients and really empathizing with them. I started by just sort of going out and doing some home visits randomly to some patients to see if that would help. I rode the metro with a patient one time who was afraid to go to a medical appointment, and she had cancer, actually up here to NIH, which ended up saving her life. So I started to kind of dabble in that, but really it began with this idea of just really having concern and empathy for patients. And then the thought was, how do we meet people where they are in the community? And so I had a couple places to ideate, one of which was the Ward 8 Health Council, which is a group that meets a lot of different stakeholders, hospital organizations, community-based organizations, and they talk about local issues east of the river. That's the EOTR. So this was a place that we could kind of marinate on different ideas and topics. And then I was also fortunate to get into the first cohort of the Robert Wood Johnson Clinical Scholars Program. And that program was really focused on wicked problems. So these societal issues that we don't really know where they start and end, they're layered on top of things, and we don't really know how to tackle them. So that was another place that I was able to kind of brainstorm and think through different opportunities and ideas. So where I started was, and this was through the Clinical Scholars Program, was this idea of embedding education in barbershops. And so this was really coming out of the idea that we needed more mental health services. So the idea was to really target a population who was hesitant to seek healthcare, which in this case was African-American men, and then bring services to the community. And in this case, they weren't clinical services, but they were more education services. So for this program and through the fellowship, what we did was we first started to train barbers and teach them some skills around mental health literacy. And then we had them kind of go back to their barbershops and talk to their customers. And it worked for a little while, and it was pretty successful, but the issue was a lot of the barbers were busy and they needed to keep, they needed to make money. And so this was sort of an extra thing they had to do that was actually more of a burden to them. So then we switched up that program a little bit and we said, well, why don't we train returning citizens? Because there was a big group of men that were returning citizens, and we thought, why don't we teach them some classes? So that image on the right is doing a workshop with some of the men in our program. And it actually worked pretty well for a while. But then we found some challenges with that. And mostly it was due to the busy barbers in their shops, and they needed to make a living. The fellowship ended, so that was a problem. 3-year funding ended. I'm not sure why the fellowship has a little fork and a knife, but they did give us a lot of food, so maybe that's the icon for that. Lack of funding, of course, is always an issue. And then we didn't have permanent space in the shop, so we didn't really have a lot of space to do this. And so then it became this other ideation of how do we find another anchoring institute in the community, and how can we create something more sustainable? So then we moved on to this concept of using these mobile buses. And so when I was working at the Safety Net Hospital in DC, there were these 2 large mobile buses shown there. And they were basically unused. They were sitting in the back of the hospital parking lot. Some of the hospital administrators had tried to bring them out, bring them to grocery shops and do certain services. But I thought about, well, what if we kind of bring these out and deploy these into the community and see if people are receptive to them? So at the time I met with the DC housing director, which was 2 directors ago, and said, would you be open to us having this mobile truck come around to some of the public housing properties? There's over 50 in DC. Would this be something that would be, effective, do you think? So the director said, yes, of course, we'll be open to this idea. So we tried to do this again for a little while. Again, funding was an issue, and we weren't getting a lot of people coming out. But then COVID hit, and so we did get some CARES Act money, and we were able to continue the program. And we were able to go to almost like 30 properties within the DC housing portfolio, the housing portfolio. And people were so open and so receptive to this, especially because they were so afraid. So a lot of times folks hadn't even left their apartment buildings, and we'd show up with a mobile unit, and they would be like cheering for the van to show up. And they'd be so afraid, do I have COVID? And so really at that point, I thought, this is about a medical intervention, but it's really about just showing up for people and saying, we're here for you. We're not going to leave you behind, right? And so we did this for a while, but we did do some pen and paper surveys. And what we learned was that people love the place-based services when we came around. They love the idea of on-site services, but problems were the mobile could only do like one place a day. And so we show up maybe at one housing property and we maybe say, well, we'll see you next Tuesday or when we can come back. So the lack of consistency really became a problem. And then the mobile vehicles are expensive. There's maintenance. You have to get a CDL driver. There's gas. We constantly had issues with some of the equipment on the vehicle. And we thought too, maybe we don't need all of this equipment. Maybe we could be a little bit more flexible and a little bit more mobile. So then I had this idea, and this is literally like the paper towel that I wrote on. And I had this idea of what about if we anchor wellness hubs into public housing, because public housing has this amazing infrastructure of multiple properties that are dispersed around the city, most of whom have Medicaid or are dual Medicaid Medicare programs. We could offer, clinical services on site, but we could also bring in some of the other community partners who are doing social services. So we would have this sort of infrastructure, almost like an FQHC flipped inside out, right? Wraparound is in the community versus being within the confines of the health center. We could do wellness games and contests. We could bring in students to do student training. So I had all these different visions of these things in these anchoring institutions as the DC housing portfolio allowed for. And so that's when I came up with this idea for C3 Cares. So C3 Cares is basically a nurse-led model that is embedding wellness hubs inside of housing. And so the idea is that we have staffed by community nurses. And so these are nurses that are, out in the community. They serve almost like a school nurse model. So a lot of times people say, is this kind of like a minute clinic model? And minute clinic to me is a little bit more transactional. This was more like a school health model where you have a known person that's there in the community. We also use community health workers. And in our case, what we've done is we've actually employed residents who live in the properties, and we've been able to put them through public community health worker training program through IPHI, had some funding. So we were able to train them and then bring them back to work on the properties and work in the clinics. And then you have nurse practitioners who can do telehealth, can be in person on site, and can also do different wellness events in the community. So the idea is that this is early, it's convenient, it's hopefully upstream model, and really supporting this care coordination and addressing health issues early. So those are some of the services that we can provide. And now we have 3 that are Medicaid approved in wards 6, 7, and 8. We have a 5th site that is actually on the 2nd floor, so we can't get that to be ADA compliant for the moment. But the idea is that these would be small clinics, maybe serving no more than 800 to 1,000 people, so they stay very intimate, but then there are multiple that grow around the city. So here's a commercial that we made. That's always good.
C3 Cares is here. It's right down the street, round the corner.
What C3 Cares has been doing is really breaking those stereotypes and meeting people where they are.
C3 Cares is an awesome option for people to choose.
It really gets me excited about what's going to be possible for the future.
My name is Regina Murphy, and I am employed with the United Planning Organization. I work directly with the residents in public housing.
My name is Darius Baxter. I'm the president and CEO of Good Projects. We work hand in hand with C3 Cares here in the Southwest community.
My name is Shayna Marie Potter, and I am a community health worker with C3 Cares. By you being here directly in the middle of the community, it's more accessible.
Yeah, it is too good to be true to have a world-class facility right here to make sure that your basic healthcare needs are taken care of.
You all do immunizations, you do the flu vaccine, you do the COVID, you do health assessments, you do referrals, you do prescriptions.
Popping up at events to be able to provide basic screenings of vaccines.
Education workshops.
Really showing people that healthcare doesn't always have to happen in a doctor's office.
The mixing and mingling of the community.
We're seeing people proudly stepping up and being like, hey, I want to take control of my own life. A large part of that is their healthcare.
The whole outcome would be to make our neighborhood a more healthier, sustaining neighborhood.
When they're involved in the medical field and they're participating, that means healthier people, and healthier people mean healthier communities.
C3 Cares is here.
And so, kind of lastly, that's back on. Lastly, this is, again, sort of a larger depiction of this wellness hub model. And so C3 Cares clinics are sort of in the middle of it, but then you have all of these other services that are sort of built around it. and then some of the community partners that are already there, because currently there are about 50 social service providers within DC Public Housing's properties. And so these are some of the partners that we've worked with. And so to me, this is just the beginning of a model that could really be demonstrated in Washington, DC, and then be expanded to other cities that have similar infrastructures. And what are the expected outcomes of the model? I think, first and foremost, we want to reduce some of those emergency room visits. We want to make sure that people, understand their health. And so addressing health literacy, I think, is probably first and foremost. I think that, health literacy can't be addressed in a 15-minute medical appointment, and we know that. And so if we can build some programs around, educating folks on site where they live, I think we can start to kind of work some of that so that their office visits don't have to be so intense and don't feel like they have to be so fit into a small visit. Engagement and care, of course, that is a priority, is really trying to get health to be a shared value for people living out in the communities. Improving coordination of care, so by having on-site social service providers and other wraparound, I think this could really, improve the coordination of care and really get more folks involved. Community level trust, this isn't something that I've mentioned so far, but a lot of people have a lot of fear and mistrust of the healthcare system. So some of that is just rebuilding that trust. I think nurses are the perfect folks to do it. We're the #1 trusted health professionals or professionals for 17 years straight. So I think that will help build trust and restore trust within communities. And then for students, so far we've had nursing students, business students, we've had public health students coming out, but I think there's more and more opportunities for different types of students and different interdisciplinary types of projects to occur at these sites, at these wellness hubs. So here's some images of our clinics, of our flag, of our education session over there on the left. We had some nursing students do a small presentation. And there's a picture up top of one of our primary care, just the entryway, which is basically the clinics are just converted 2-bedroom apartments. And so we have been able to check the boxes for Medicaid to say we have 2 exam rooms, we have 2 exam tables, we have a private entryway. We've become ADA compliant on one property by building a ramp off the back. And so we made the kitchen area into a little exam room and then have 2 other rooms upstairs, which were the bedrooms converted. And so this is really the model that I see, and I'm happy to answer questions or have more discussion. Thank you.
Okay, thanks so much for that presentation. And I am delighted that I get to provide some opening remarks and set up some questions for it. Just a little about my background. My first job out of nursing school, I became a school nurse in the city of Camden, New Jersey, and many of my students lived in public housing, and so get to see the importance of being able to take care of that population. And I was also a pediatric nurse practitioner, and I worked in public housing in North Philadelphia. As a nursing professor at Hopkins, we are very interested in thinking about restoring community nursing. Lots of what happened in the conversation today has really been around nursing actually came from the community. We went in, got dragged into acute care health systems, and now we need to get back to where we were. And I think this is what you talk about in your conversation, and what you're doing is really a part of that. And I actually wrote an article that just came out in the spring, and the title of the article was going to be A School Nurse for Every Census Tract. We changed it to Restoring Community Nursing, but it's I love that idea of school nurse forever, because I think school nursing is a good way to look, a good lens to look at it through. And we actually at Hopkins, we just this spring, we are going to have first cohort, a pilot cohort of entry-level nursing students who are going to do all their clinicals outside of acute care systems. So they're going to get all their hours, which is really exciting for us. And I think it's really going to be exciting for nursing education. I thought it important to share a couple facts about public housing. A lot of what's happened is thinking about the demographics of who we serve. Across the nation, there are over 1.5 million residents living in public housing. I'm not telling you anything you don't know, but approximately 500,000 children between ages 0 and 17 live in public housing. There are 36% of the residents living in public housing. Nearly 90% of residents in public housing are seniors. 38% of public housing households include a member who's disabled. The average annual household income of households for residents of public housing falls well below the poverty line. So I think you really went over the healthcare inequities, the social drivers of health. We're not going to say determinants anymore. We're going to say drivers. I really like that. Great day. And the innovative solutions, I think the nurse-led wellness hubs, I mean, I think there's those are great pieces of it. So I won't look too much over that. I do want to leave some time for conversation because I could talk about this all day. But yeah, the engagement care is such an important piece. But of course, as you know, we really want to emphasize that clinical care only accounts for probably 20% of health. And there's all those social drivers that we really want to kind of lean into. I mean, I think your point about the zip code, more important than genetic, is just great. This is an idea whose time has come. We have a growing number of models across the country that are really engaging, thinking about nurse-led models and how we can provide care where people are. I love that this focus seems to be about what we're doing with communities versus what we're doing to communities. I mean, it sounds very collaborative, that you took the time to really leverage trusted members of the community, starting with barbers, working into promotoras and community health workers. I mean, obviously, you see a piece of that as well. And a lot of it intersects with the conversations that we've had with as the advisory members to the NINR. I mean, this is really something that we're thinking about is think about the interventions delivered at the right time, at the right place, the right modes, and really thinking about these social drivers of health. And as we've talked about today, the NINR is actually in that direction. 47% of the funding is going toward these social drivers of health. So this is just something that is really timely. I'm just really so delighted that we brought you into this conversation because I think it's really important. And I think Dr. Zink has done such a good job of bridging and finding the different stakeholders and thinking about community-based nonprofits like yourself, higher education, philanthropy, our acute care partners, because they're all part of this conversation that nursing really is, as the largest share of the healthcare workforce, should be part of it, as most trusted, as you pointed out, should be such a part of. So I'll put out maybe a couple questions. We'll address them, maybe we don't. But how can nurse-led systems and models of care be effectively implemented in public housing environments to address the unique social, economic, and healthcare needs of residents? I think you've definitely touched on that. I mean, how can these, as we center nursing, I think we also have to be very aware that we need so many partners, right? And we need community health workers. We need to think about our doulas and promotoras and our social workers and our policymakers, and how do we engage them in this conversation as we think about really widening this sense of how we address primary care, where people are, and where they want us to be with them. And I love that in that commercial said, yeah, you don't have to go into an acute care setting to get health care. And when everyone engages with healthcare, then we all get healthier and our communities become more equitable and more resilient, and just healthier places. And the last piece is, like, again, I think really thinking about the role of community health workers as we bridge that gap. And I think, what you did with barbers, I'm sure we can also do with other community health workers, but how do we work in there? And I think we have seen other models. I mean, I know Jeff Brenner, some of the work he did, really thinking about the different layers of nursing assistants and LPNs and RNs and nurse practitioners in these models. So just so much. I really love that you came today. Thank you for all the great work you're doing. And I'd love to open up for conversation. Thank you.
So Erin, first, I just want to say that your presentation was spectacular for all the reasons that Bob just articulated. So I'll just be really succinct, but simply say that you are an amazing nurse and an amazing example of what healthcare can be in our country. And I think the We Cares is sort of the wave of the future, and you're sort of there now. And so, huge congratulations and thank you for being here today. I just want to point out, a little bit of sort of promotion of the nursing profession, which I think is part of our role, So I just completed a review of hundreds of programs that have been published. And so obviously not things that don't show up in the literature, but if it's in the literature, sort of critical review of what do we mean by nurse-led? And are there a set of components that actually define across populations and across settings and across issues? And it turns out that, at least from my review, there is. And I think many of those things are in your 3C cares program, or C3 cares, sorry, C3 cares. But what I'm trying to lift up is that while this example is fantastic, we need to combine that with the hundreds of examples that help us to tell our story of how nursing research is transforming health in our nation. And, Shannon, that paper is out, and I'm happy to share it with you guys. It's open access, and it really defines, like, at least a first stab at, like, what makes nursing interventions impactful. And so just wanted, and Erin, I think I'm going to make sure I send it to you personally if I can get your email before you leave, because I think you'll see yourself in that, and I think it will show you that you've been part of something that is really important to elevate.
I see your hand, Dr. Stone.
Yeah, thank you so much. A wonderful presentation and absolutely amazing work. There's no doubt that you're changing lives. What struck me is I'm old, did my postdoc over 25 years ago, and I heard about models of care like that. They were not nurse-led, but models of care like this 25 years ago that they were doing in Harvard. And so I'm reflecting on that and thinking, as a nurse scientist now, what are the questions, the scientific questions about this? Is it about implementation, how we get people on board? And I'm not sure of those things, I mean, if I heard about something very similar to this, of putting clinics in housing projects over 25, small clinics 25 years ago, and it never happened, to me, I think then the questions are about why and how do we implement them, and get them implemented, so they're real policy questions, but I just want all of us to reflect on what are the scientific questions that we need answered with such amazing work going on to get this implemented larger across the nation.
My question is, what can we in acute care learn from you? I mean, how do we get patients engaged in their care? Because we see the implications of when they aren't engaged. And it's a very difficult to treat population. They keep coming back. Their outcomes are terrible. So I would love to learn from your experience on how you engage people in their care. Because clearly you've solved the access, but how do you engage them?
Yeah, I think that's the $1 million question. I don't think we've gotten them. I mean, I think we're working towards that. And I think it has to be more than the healthcare environment. Like even in our little mini clinic, like that's not going to be it either. And that's why I go back to this concept of the wellness hub, of really making like a safe space where people could come and get information, pre-licensure nursing students sitting around helping people apply for Medicaid, helping take a blood pressure, just making that sort of in people's space so that they get comfortable and they get used to it. Because, if you've had a lifelong, low health literacy your whole life, it's very challenging. I mean, I'm sure you're seeing it. I'm seeing it too. What is diabetes? Like, I don't know. I have 2 insulin sticks. What are they? How can any of us address that so quickly, right? That's going to have to be time. And that's going to have to be, time in settings that are more comfortable. I mean, I love the idea of like the groups and having, the groups in these community centers where we just talk and we have other people ask questions that are the stupid question that somebody else didn't want to ask, and really make it kind of like down on everyone's level, because this fast pace, get admitted, it's overwhelming, for all of us, but, even more so folks that really have very low health literacy. So I think it's got to be just over time. But I think that is like the question.
And if I could jump in, a lot of it is trust. I've been in the housing industry for over 20-something years. I was born in public housing. I spent my formative years in public housing. And so we all know that trust factor is a big hurdle to get over. But my job as an executive director is to rebuild that trust. And the one decent thing that I can say, having come back to D.C., because I started in the Housing Authority in D.C. in 2000 and got convinced to come back to help fix the Housing Authority now, is that we're starting to rebuild that trust with the residents. And once they see leadership showing that they care about them, that makes Dr. Athy's job a lot easier. Now, she didn't need my help because when I met her, she was doing well. So I'm the benefactor of these services. But having traveled the country and spent serious time in New Orleans after Katrina, with the Housing Authority there in D.C. and other places, Gary, Indiana, clearly there is a need for it. I love the model. I'm here just to support her and to say whatever you all can do to assist her with this program and expand it. It's a great idea. I'm looking at ideas now, but my agency, as I put together a recovery plan for the Housing Authority to expand these services to as many properties as possible. I'm rehabbing units right now, and so I have a huge portfolio, and I'm going to be committing some of these units to carve out some space for her and her team, because not only is the healthcare part of it, it's job opportunities for residents. You know, we have a training program for maintenance workers, but they also want to be nurses someday. You know, so there were a lot of different factors in this program that really just blew me away when I met Dr. Athy when I was walking through the property with the residents to talk about some of the issues. And the other piece of it is, and I never looked at it from her angle. So I'm a developer as well, and I redevelop properties. And so when you start thinking about redevelopment, you start thinking about mixed-use properties, you know, you want to put these health clinics at the bottom of the building so the residents can live on the 5 floors that you build above it, or they have access, you know, to medical services as opposed to trying to get uptown to Sibley, you know, and things like that. So, but now that there's this community model that I see that my residents are enjoying, number one, that I just fell in love with, number two. I'm just excited for the program. I'm sitting down and talking now about how I can expand the program as well, but any assistance you all can give, I mean, I think will be great as well, because clearly we all agree that there's a need. And the question is a fair question about how do you engage them. But I think that goes back to the trust factor. And once you start to build it, you know, as they say, what was that, the line in Field of Dreams, Kevin Costner, if you build it, they will come. You know, so it's sort of like that's sort of that concept. But anyway, I'm just here to say, great program. I appreciate her. I have to run now. I speed up some time to come because this is really important for me and my residents. But I just want to thank you all for it. So allowing her to do the presentation and allowing me to share a couple of comments. So thank you so much. Thank you.
Good afternoon. Karen Dale. I'm the CEO for AmeriHealth Caritas District of Columbia and the Chief Diversity, Equity, and Inclusion Officer for the AmeriHealth Caritas family of companies. I wanted to add some comments in terms of what creates sustainability and the collaboration, right, that ensures that over time we close these gaps that exist. So in the list that was discussed earlier of who the players are, I didn't hear payers listed. Without a mechanism for payment for these services, without the ability to look in a comprehensive way at the whole person and the costs, then we miss a huge opportunity, right? You know, I tell people that the future of equity is all around collaboration, reimagining the healthcare delivery system as not just a healthcare delivery system, but one that's grounded in social equity. And when those things happen, the payers can be really strong partners, and they can help to provide the sharing of dollars through alternative payment models that allow for us to keep the change going, right? So what I want to just say a little bit about why this place-based work is so important. One, nobody is raising their hand saying they trust their insurer, right? But there's a nexus in terms of our ability to say, here, for example, you know, we've done this, mapped all the public housing properties. I cover about 120,000 district residents and looked at where we had the gaps in care. So where are persons that are diagnosed with diabetes, hypertension, high cholesterol, whatever the things are, and said, how many residents live in that building with that diagnosis, and how many of them are not having good outcomes? and then share that with our community partners so that then they can tailor the supports and services. What they also do really well is to be a bridge. So I don't expect that they will provide everything, though they've had lots of great partners, but we are paid to look at and take risk on the whole cost for that person, right? So when we have a suite of services, like we have medically tailored meals, we have grocery delivery, we have dietitians who will go in home, when we braid all of that together, that is where we really see the multiplier effect in terms of outcomes. And so, yes, I love my FQHCs and many of my traditional Medicaid providers. However, the mom that has more than 2 children under the age of 6 is like it's really challenging, right? And what is Medicaid? Mostly moms and babies. And so getting to know in a deep way the community we are serving, getting to understand their preferences and challenges. And I say both preferences and challenges because sometimes we are leading with what it is we want versus what that person's most urgent need is. And so we keep coming back to the conversations that we have with our enrollees. We come back to the conversations and touch bases with our partners so that we continue that learning. And in that learning, growing, and scaling is where we can reduce total cost and invest in that. Like, I'm always proud that we've had probably 7 years of experience with community-based organizations, is that usually, right, by year 2, 3, 4, we are talking about how to implement value-based contracts so that they're getting reimbursed more, right, for helping to align around the outcomes that matter, not just because it reduces my cost, but because it improves lives and improves quality and outcomes. And so that's, to me, the model of where we all should be heading. CMS is doing great work, and I serve on one of their committees to help us move this work forward. I will say one plug for nurses is that I think we are thinking differently. Like, people say to me often, the things that I've stepped off the curb to do before other insurers would step off the curb to do it because they're hung up on some really high ROI. It's because I deeply believe in our capacity as human beings to help others through collaboration, engagement, and not giving up. And I think that comes from our training as nurses, right? Like, we don't just go in and say, well, that didn't work, and then we let it go. We are persistent in that desire to improve outcomes and care deeply about human beings. So I couldn't be more proud that you asked me to come today because I am just excited about the future, the possibility, and the way that we can together push this forward in a way that makes humongous difference. That's what I'm going to say. So proud of you.
Sorry, I thought I turned it on. Dr. Beth, you've solved a very important problem in a community that's urban and that has full practice authority for APRNs. So I think some of the challenges that we need to think about as scientists is what about those other states that do not have full practice authority, many of them with much larger communities that don't have the ability to function in the same way. And then, while I realize this may not be your bailiwick, how do we take this model and replicate it in rural settings or do something for those rural people because it's, well, somebody used the word earlier, healthcare deserts. You know, how do we get to those people and engage them in their healthcare? So, excellent work. Thank you.
Unfortunately, it's my job to stop us there. Thank you so much for coming. Thank you for what you're doing. You've inspired me, and I think all of us around the table. I think our job, as Dr. Stone pointed out, is what evidence do we need? There's probably different types of evidence, including what kinds of policy, relevant research do we need to expand and grow these types of models. And thank you for being an inspiration and for the work you're doing and for joining us. So thank you both. So we're going to switch gears because some of us, not me, but some of us are on tight timelines. And so we'll move to our next agenda item. So I'm going to welcome Dr. Allison Colbert, who will discuss operationalizing or just talk about research through the social determinants of health lens and broader activities we're doing here at NINR. So as I mentioned earlier, Dr. Colbert is an advisor in the Office of the Director here at NINR. She's joining us on an interagency policy agreement from her position as a full professor at Duquesne University in Pittsburgh. So Dr. Colbert, when you are ready, I'll turn it over to you.
I was born to put it back on. This is a chance.
Thank you very much for having me. I have the honor to work in the Office of the Director at NINR this year, and the absolute privilege today to talk a little bit about the work specifically around the SDOH lens at NINR. And I've had the opportunity to talk with people and to learn about the work being done. None of this work is mine. I just get to talk about the really cool stuff that other people are doing. It aligns so well with the conversation that I've heard today. And I think it's no overstatement to say that NINR has emerged as a leader in SDOH-focused research. And the staff here is exploring the best ways for the Institute to continue these efforts, maximize the opportunities, and contribute to the highest quality research. There's also an opportunity to ensure that nurse investigators are well prepared to do this work. And so using some of the terminology that we've all been talking today, really my job is to tell a little bit of the story about the SDOH work at NINR. And Dr. Zank and Dr. Anklin, as the Deputy Director, have sort of recognized the need to tell this story a little bit louder. They are do the work people, as you can see by the results. And so I just have the opportunity to talk about it together and to talk a little bit about, what the goals are and how they're being measured. There is no need for me to repeat that nurses and nurse scientists are acutely aware of the importance of SDOH research. It's very convenient that determinants and drivers are the same letter, right? So now that you've changed the terminology, we can still use that. We can ensure now through the work of NINR that the opportunities, tools, and resources needed to do this really important work are available. So everyone is familiar with the lenses and the 5 research lenses, and social determinants of health is one of those. And SDOH is at the top of this framework, along with health equity, to encourage researchers to view those two things as primary foci on which to consider the other lenses. And we're going to talk about the SDOH lens in a little bit more detail, a little bit faster than we had intended. So the activities related to SDOH and NINR can be organized into 3 primary goals. These are not necessarily mutually exclusive. Of course, everything is contributing to the first one, right? Advancing the science and improving and optimizing health. But they can be viewed in terms of audiences or where those efforts are directed. First, of course, we have advancing the science of SDOH research to optimize health and well-being for all. Second is positioning NINR as a leader in SDOH research, both internally, at NIH and externally. And finally, preparing more nurse scientists to lead and conduct rigorous, high-quality research in this area. And to achieve each goal, the NINR staff has developed specific strategies, some of which have been implemented, some of which are early in the phase of discussion or exploration. And we can talk about a few of those in greater detail. Again, of course, all activities move towards this goal, and the scope of this work can be illustrated several different ways. I would argue that the variety of funding opportunities and the investments NINR is making towards these efforts provides the most direct evidence of how this goal is being achieved. These are examples of the various funding opportunities originated with NINR as the lead. The topics have clear SDOH implications and provide researchers with a variety of options. As with most activities related to SDOH, there's those that are directly and explicitly about SDOH work, And then there is other work that has SDOH considerations, and NINR is working to ensure development in both of those areas. In addition to the efforts that are directly led by NINR signs on to other opportunities. And these are, again, just a few examples of opportunities that NINR has signed on to from a variety of different institutes, NIAAA, NIMHD, the Office of Disease Prevention, and that cover a wide breadth of approaches, including strengthening capacity, as well as looking at models of care and translational science. You can really see a variety in scope when you look at the opportunities together. This should look familiar, and we've talked about it in great detail today about the increase in both the proportion of the budget invested in the actual dollars. As Dr. Zank mentioned, these are not mutually exclusive. And for me, this table reflects nursing's holistic perspective of health, right? That extends from the individual through the community and to the greater social context. You can see it in the way that NINR is investing the funds. Research in SDOH is expanding every day, obviously, and NINR wants to respond quickly and nimbly to emerging issues, opportunities, or crises. And this can now be done through what's called strategic imperatives. For NINR, strategic imperative is an ongoing focus and investment in a specific area of research that's aligned with the mission and guiding principles of NINR, most specifically the social determinants of health and health equity. Additionally, strategic imperatives are those that we have a potential to make a significant difference. The strategic imperative is also a way to highlight a particular SDOH or emphasize the lens. Needless to say, exposure to firearm violence is in and of itself an SDOH, and firearm injury risk is deeply influenced by many other social and structural factors. This, among many other reasons, including the significant inequities there are in exposure, morbidity, and mortality, it made firearm injury prevention a particularly strong choice for the first strategic imperative. This is something of a cycle, the strategic imperative, which includes introducing an idea, learning about the latest science, developing responsive concepts and funding opportunities, as we saw with firearm injury prevention, and then integrating that work into the broader activities of NINR. This also means that the staff will begin the process of selecting a second strategic imperative with those same goals in mind. The second overall goal is to position NINR as a leader in SDOH research, and there is already strong evidence, of course, to show that this is happening both at NIH and externally. First, looking at partnerships and collaborations, which can be categorized in two different ways. Initiatives that are primarily focused on SDOH explicitly. So those would be some of the examples we've already discussed today and at previous meetings, like Compass, Transformative HD, and the SDOH Research Coordinating Committee. There's also been opportunities where the SDOH perspective is provided to widen the scope. So that would include things like the Improve initiative related to maternal and child health and the Climate Change and Health Initiative. NINR and Dr. Zank have also had leadership roles in federal efforts to address SDOH. This includes NINR as the NIH rep to HHS's SDOH leadership group. And Dr. Zank was the NIH lead at the White House Interagency Policy Group on SDOH, which produced the White House Playbook this last fall. Needless to say, these examples of leadership are adding up quickly in this area. Two other ways in which NINR is positioning itself as a leader include the development of infrastructure for grantees across NIH and providing research resources for the broader research community. We've seen opportunities like directors' lectures and longer virtual workshops that do that. NINR staff is also exploring new strategies for this goal. That would be ways to aggregate research resources for use. One we want to talk about in a little bit more detail, which is just something that's beginning to be discussed, is common data elements. Obviously, this group doesn't need to be sold on the value of common data elements, which are used to ensure some degree of standardization of measures and comparability of findings across studies. We know that if they're done well, they allow us to leverage existing data sets into meta-analyses. And given some of the methodological complexity of SDOH work, with which Dr. Beckemeyer alluded to earlier, investigators who are just beginning in this area could potentially benefit from the guidance and guardrails that strong common data elements provide. One could also argue there's a very real need across disciplines to explore the use of CDEs in this particular area, and that NINR, along with its partners, has the expertise required to meet that need. The third and final goal is around preparing more nurse scientists to lead and conduct rigorous, high-quality SDOH research. And there have been several ways in which that has happened and in which that have resulted in exciting investments, one of which we talked about earlier, which is the Social Determinants of Health Summer Research Institute, being led by Dr. Acklin, the Deputy Director. I'm pleased to report that we've had a very robust response to this particular program, the announcement went out in May. We have way more applications than we thought we were going to have, which is fantastic. This opportunity is for nurse scientists, and we have a folder full of emails of people very disappointed that it's only nurses. They're excited. They're very excited to learn from NINR and the experts who are affiliated with NINR about this really important work. That is happening at the end of July. Selections for that are coming out in June. Other ways, of course, that this is happening include undergraduate opportunities to expose undergraduates to research, and other funding opportunities, specifically R25s, one on SDOH, one on firearm injury prevention. These continue to be important ways in which we provide nurse scientists with the skills that they need. We provided a few discussion questions about these areas, opportunities now or in the future as we sort of catch up with time. But I think there's some important questions around the ideas that Council has for initiatives in this area and building momentum for new researchers. So I will turn it over to you for any questions that you have.
Yeah, thanks so much, Dr. Colbert. It's fascinating to hear an overview of a pillar that's so important to this institute and to see what progress has been done and kind of a future view. So I kind of have some questions and comments that in part are about what has been accomplished already, and then a little bit more about what remains to be accomplished. I think social determinants of health is kind of like our health disparities discussion earlier, that there's a little bit of an unknown that nurses and NINR specifically have been doing this work for a long time. So I do think we almost have to take a step back and find better ways to kind of capture what has already been done, even from an institution's perspective. You know, we heard Dr. Grayson mention earlier about health disparities in a new way with this RCDC coding. I wonder if at some point we could see like something similar with social determinants of health and see what NINR has funded, if that's a useful coding mechanism. Because it would be great to similarly see how many grants have been funded, how many of them are ours, how many of them are training grants, just so we can kind of see similarly all the great work. And then specifically what other grants that have been funded, what's their focus, what's the products of those, I think would just be a great way to help us kind of tell our story of what's already been done. Given that it's number one of NINR's budget from a percentage, and then we are number two at NIH in terms of percentage of the budget too. So important. So let's think of good ways to use numbers and to be more compelling about what has been accomplished already. What remains to be accomplished assuredly is a lot. But the common data elements is actually quite fascinating. So I'm glad that you mentioned it because, of course, people are enamored with that, because what better way to have additive research and allow for additional data sources. Everyone is guilty of this. You know, if you're measuring food insecurity, you're going to do it the way that you know how to do it, but you may not do it in any similar fashion than any other investigator who's also studying food insecurity. So that's kind of like the benefit of common data elements. The drawbacks are is that they can be prescriptive. They can be not relevant to the community. It may not be preferred, or it may actually not be questions that are answered because the community of interest doesn't want to address those questions in a similar way. So the common data element, I think, is something that the Institute should definitely consider. It's a great way to really capitalize on making sure that the work going forward is additive and can be kind of considered in these meta-analytic or systematic ways, as you said. but they are always a little bit of a double-edged sword. So I think it's an amazing overview. And then if you have any thoughts or questions on, the number of grants that are funded kind of under the social determinants of health, or where the breakdown is in terms of training and independent grants, that would be interesting for us to learn about at some point, but not necessarily today.
Yeah, I think to address the last one, but the data people are working on those exact things, right? Trying the best way to track that, which also then leads back to the first one, which is about the shared language, right? And understanding about SDOH. So Dr. Zank is co-leading the research coordinating committee, which has released a conceptualization, which, shockingly NIH didn't have, and now does, right? That is a shared common language around that. And I wouldn't speak for her about what that is, but I think that, a lot of those efforts are about coming to an agreed place about what those things mean. And I would, in terms of common data elements, you've identified the exact problem with it. And, from my perspective, I think that NINR leadership would do common data elements differently, right? So it's not about deciding, for communities what those look like. And I think it's an excellent opportunity to, really include community engaged efforts in order to establish what those are, rather than to dictate it. But again, early stage, lots of opportunities for NINR to do this work deliberately with the rich tradition of nurses, for sure.
And then happy to open it up to my colleagues as well for comments or questions.
Oh, actually, I'm curious. A question, maybe you can answer, Suchi. I'm curious about the common data elements for SDOH. I thought the Compass program has already have a pretty comprehensive common data elements for social determinants of health. I'm not sure how what further work is needed. I guess I'm curious where NIH in general is in the space of common data elements for SDOH.
I can address that a little bit. There are, through the Phoenix toolkit, I think everyone recognizes those probably need to be updated. So there are some. It is true Compass will be coming up with a set of common data elements for that work that hasn't been established yet. So that's work to come. I think the Research Coordinating Committee, CDEs, right, are a big discussion at NIH in general. The coordinating committee knows that and recognizes a need there. So I think part of, for me, thinking about CDEs and us at NINR, right, what voice do we want to have? Do we want to contribute our perspective as these things roll out? And so the idea of a working group has come to our mind, whether the council wants to form a group to help as these things increasingly over the next year start rolling out. Do we want to have a chance to get together as a group and decide for us, right, what we think is important and to be able to put that on the table? So I appreciate you digging in on that.
Yeah, because I'm just thinking about, more of the innovative nurse-led models in the communities where there should be this referral to social services organizations after you identify and screen social determinants or social drivers of health, but also refer back to the health system, nurses or nurse practitioners. So it's a closed loop system. And when we think about CDE in terms of research, maybe we need to also think beyond just identify the data elements, but also in terms of down the road, the interoperability with electronic health record system and kind of the closed loop referral and referral back. And I think that will be, instrumental when we identify these common data elements to drive more where we envision nurses and nurse practitioners can have those new models of care in public housing, rural, and all of those other areas. So I see it broader than just from that interoperability lens.
No, thank you for that comment, and this presentation is amazing. I would say as Dr. Zank was saying, Compass hasn't gotten there yet, but the Phoenix toolkit, there's a lot of issues with it. So we're using it right now. as a way to determine how to identify common data elements from an electronic health record from federally qualified health centers. And what has been really interesting in this process is the nurse leaders who are part of this effort are really looking at it quite differently, because they're looking at more of the modifiable determinants or drivers compared to what I think has been done with Phoenix to really just characterize a population. I would also say that we talk about community voices, but I like to think about it as organizational voices who would then be using that data to seek funding to support things like the housing efforts. And so I think that that's another voice that would be nice to see as part of some research effort to better understand identifying common determinants that other organizations can use to help their communities as well.
Just to build on those comments, but first I just want to say, Allison, that was fantastic. And I think that the presentation really highlights what we heard throughout the morning and up until now, that, you know, NINR is doing fantastic work in this area. I think that's sort of top line message. In terms of the 2 points that you raised about what research and the scientific contributions that NINR can make, and then also this issue of common data elements, just a couple of thoughts. I think there are lots of models, I would say, and hopefully this isn't an oversimplification. Many of those models are fairly static, and so they do a good job at describing things. And one pleasant thing is that I've seen in the more recent sort of announcements regarding funding that there's been the use of the word mechanisms, and that's fantastic. Because if I were going to make a recommendation around research or common data elements, I think nursing can make really important contributions around mechanisms and having a set of common data elements that would be specific enough, but also generic enough that they would account for differences in population and context, et cetera, all the ways that we differ, but they would still guide the development of multi-level interventions. And I want to also push a little bit on the tension around health-related social needs and the tendency to focus on screening and referral, which I think is a first step, and I'm by no means minimizing that, but I think we have evidence that it's inadequate and that we need to go further. And so I think those are areas that we're already leading. And so why not, Shannon, you know, keep pushing forward? And that would be my recommendation.
Any other comments? I know we're getting towards the end of the day. So for me, I guess I want to so thank you, Allison, for that. So I hope you found that valuable, because we are hearing, right, it's not clear what we're doing, right? Like, for example, with health disparities, the Institute has been leading, has done a lot of work, right? So SDOH, right, you saw the graph at the beginning, we're, you know, greatly expanding our investment there. And our leadership at NIH and more generally. So that was an attempt to get everything, right, to show the progress all in one place in terms of across research, training, and then leadership more generally. So that was the purpose of that. And again, to help keep John employed, maybe he's left because he's busy working on data, but we can build, right, on that presentation and then show you some data. So like, I think to help you guide us, right, about where we should be more specifically investing our money, to give you more specifics, like Dr. Lee brought up, right, what does that portfolio look like in more detail, so we can, you know, use your expertise to inform our next steps as we move forward. So we'll keep John employed so he can help us with those data elements. I think the other thing I've really appreciated, I've done some rounds of meetings, right, to check in with how we're doing, and I've appreciated all the offers to help us, and not just at the meetings, but in between. And so building on this conversation, as we've talked about, how do we, you know, figure out our next steps under this lens and to increase our impact, there's two areas for us that stand out right now. One is around CDEs. There's going to be a lot of decisions, a lot of movement in this area around SDOH. So we wondered if council wanted to lean in and form a working group in that area to help inform, so we can have a clear voice at the table, as well as inform for ourselves directly, right? What do we perhaps want to suggest as common data elements for NINR funded research. So that was one area. And then second, in the area of training, we've been just really pleased with the interest in getting training in SDOH, right, through the R25 mechanisms and through the Summer Institute. So there's a need in that area. So we wondered if that was another area where council would lean in and advise us in terms of next steps in training activities. So I wanted to put that out there and see if there was, I see some nods, and so wanted to see if people are on board with that, want to amend those ideas for possible working groups. Any thoughts immediately? Oh, John heard me. I was guys, like what? Yeah.
I think both would make amazing working groups from this council. Absolutely.
Yeah, sorry, training. Yeah, you're like, I can't decipher in all those words what you said.
Common data elements and training.
Common data elements and training. Yes. Yes, Dr. Beckman.
So short answer is yes, I agree. But one thing that's been rattling around in my head this whole day is that, you know, we're talking a lot about how excited and impressed we are about NINR being such a leader in this area around health disparities, minority health, SDOH, et cetera. And to me, and I think that's amazing, and I totally agree. At the same time, with such leadership comes obligation, right? And that it gets me thinking, well, what if all of NIH was the bars were as high as ours in terms of percent of funding going to this area? Like, we would change the whole nature of people's health in this country, right? So what's our obligation to have influence on with other institutes? And I know you're doing that with some of the calls and working with other institutes, et cetera. But so and also our money for NINR is small compared to some of these other institutes. So if NCI or some of the others had the same kind of percentage, that would be really amazing. So then what that gets to my thinking about the CDEs, for example, is, well, let's do this, and let's be a part of developing these CDEs, and people have said here, we think a little differently. Nursing scientists do. So let's have influence on those, and let's be developing this and doing some early thinking about this before somebody else does and tells us what to do, kind of thing. Does that, you see what I'm saying? This is all recorded and everything, is it? Anyway, this is just my rambling, so I don't know if that helps.
Okay, so we're going to lean in and we're going to be calling you or emailing you to ask for your help. So we appreciate that in advance. So thank you. This was a really good discussion. Appreciate the advice and the guidance. So we are going to very quickly transition to our next guest, who is joining us virtually. So let me introduce her. Welcome. I can see you on the screen. So recently, the President's Council of Advisors on Science and Technology released the report, Supercharging Research, Harnessing Artificial Intelligence to Meet Global Challenges. So this report highlights the challenges and opportunities in harnessing the potential of AI equitably and responsibly to foster scientific discovery. At NINR's AI methodological boot camps in 2020 and 2021, we acknowledge these opportunities and challenges as they relate to health outcomes. So today, I am pleased to continue the conversation and to welcome our next speaker, Dr. Oma Lola Ogunyemi, who is joining us virtually to speak on artificial intelligence and health equity. Dr. Ogunyemi is the Interim Vice President for Research and a professor in the Department of Preventive and Social Medicine at Charles R. Drew University
of Medicine and Science. She also directs the university's Center for Biomedical Informatics, which focuses on providing biomedical informatics solutions that benefit medically underserved communities. Her research interests include computerized medical decision support, reasoning under uncertainty, 3D graphics and visualization, machine learning, and telehealth. Her work includes an NLM-funded R01 grant to explore diabetic retinopathy prediction from Safety Net Healthcare System clinical data using different machine learning strategies. She has been principal investigator on an NLM study, also on computerized decision support for penetrating trauma, and on NCI-funded R03 on individualized breast cancer risk prediction using Bayesian networks. So welcome to you. We are pleased you could join us, and you have the floor.
So thank you so much for inviting me, and thank you for that introduction. I will open my slides. Can you all see my slides?
We can.
Okay, great. Thank you. So just as an introduction and an icebreaker, because I'm going to talk a little bit about myself to give the context for how I approach AI and health equity. So I was born in Ibadan, which is the third largest city in Nigeria, and born at the university teaching hospital where my parents were professors. And Nigeria has sort of different educational systems. So we start school at the age of 4 rather than 6. And in the 9th grade, because we follow sort of a British system of education, at the age of 13, a child has to make a very consequential decision about whether to go into the arts or the sciences. And that decision is made in the 9th grade. You pick the arts, you presumably go into professions like engineering, healthcare. If you pick the sciences, you go into engineering, healthcare, and so on. If you pick the arts, you go into careers like law and so on. At least that's what many Nigerian parents would like to see. And so in the 9th grade, I had to make that decision. But I was very much interested in both. I liked sciences and the arts equally. And as I mentioned, my parents were professors. My father is science education. My mother was a literature professor who focused on African American and Caribbean literature at the University of Ibadan. So I ultimately picked the sciences and started taking physics, chemistry, biology, and all of that. And until we got to frog dissections in biology, and I realized with great clarity that I was never going to be a healthcare provider. And so it's sort of ironic that my entire career has been spent at medical schools or hospitals. My family moved to the US when I was 16, and I took a computer programming class in the 11th grade and fell in love with coding and really enjoyed that. And so I majored in computer science at Barnard College, and then liked it so much that I decided to go on to graduate school in the same area in computer science. But when I arrived at the University of Pennsylvania, I discovered that there's a trauma surgeon and a radiologist who were adjunct faculty in the computer science department. I kept thinking, what are they doing here? And that curiosity led me to the field that's now known as biomedical informatics. So I wrote my thesis with the trauma surgeon serving as my thesis co-advisor. So I never let the arts go completely. And so I took my first position as an instructor at Brigham and Women's Hospital. And I started writing a work of fiction that I didn't know would go anywhere. It took 15 years, but in 2022, I had a book published, and the highlight, besides getting it published, was getting a favorable New York Times book review. So in 2007, I moved to Charles Drew University. I was recruited to start a Center for Biomedical Informatics, as you've heard, focused on issues that are, that affect medically underserved communities. So for those of you who may not know, Charles Drew University is a private, nonprofit, historically Black graduate institution as well as a Hispanic serving institution. It was established in South Los Angeles in 1966 in the aftermath of the Watts Rebellion, which had many facets to it, and one included access to healthcare. And the university's mission is to graduate diverse health professional leaders who are dedicated to social justice and health equity for medically underserved populations. And our center was established in 2007, basically to develop informatics solutions for medically underserved communities. We're funded by a combination of NIH grants, a CDU NIH endowment, as well as state and foundation grants. And the faculty members in the Center for Biomedical Informatics have backgrounds in computer science, internal medicine, sociology, as well as public health. So the context for the center and comes from the university's location. Charles Drew is located in what's called SPA 6, Service Planning Area 6 in Los Angeles. So Los Angeles is broken into 8 service planning areas for sort of administrative purposes. And SPA 6, which Charles Drew is located in, has 1.1 million people of Latin and African American heritage. And to put that in context, there's about 5 or more states that have a population less than 1.1 million. And if we think about the city of Boston, which has about 650,000 people, it has 3 medical schools. SPA 6 has just 1. So we have a disproportionately low number of hospitals, clinics, and medical specialists. Almost a third of adults in that service planning area had difficulty accessing medical care versus 26.3% for the rest of LA County. So there's this disparity in access to care still. And it's a HRSA designated health professional shortage area. And so one of the things that Charles Drew is trying to do is graduate physicians, nurses, physician assistants, rad techs, and so on, who will commit to serving in medically underserved areas to help to sort of address this health professional shortage. So this brings me to the safety net, which you're all probably very familiar with, but I was not until I moved to Los Angeles. So the U.S. healthcare safety net includes federally qualified health centers and lookalikes, as well as state and county hospitals that provide care to roughly 60 million. I think the number has gone up to 20 nationally, and about 2 million in California, regardless of a patient's immigration status, their health insurance status, or their ability to pay. And so in the healthcare safety net, we have a large number of patients compared to the number of healthcare providers. We have a lot of patients who have had gaps in their care or limited healthcare access. And many safety net healthcare clinics or hospitals are not affiliated with academic medical centers where some of the most cutting edge research is done. Some of them are, but they're really a minority compared to the overall picture for the U.S. So these are, we have institutions that essentially have limited resources, but have to provide care to many. And my view is that health information technology and informatics methods, including AI, can help to sort of bridge the gap to help to improve the quality of care and in some cases access to care. Unfortunately, many of these settings often don't have staff with the health information technology or informatics expertise. And so at Charles Drew, we make a commitment to partnering with FQHCs and other safety net providers to work with them in this domain. So that brings me to my first study at CDU. A year after I joined the university, I was called into the office of the dean of the College of Medicine at the time, who was an ophthalmologist. And he explained that one of the faculty members at CDU, who was the medical director of an FQHC at the time, had a situation that he thought we needed to sort of try to figure out. The faculty member was an internal medicine doc. FQHCs, as you know, for the most part, provide primary care. At least back then, the focus was on primary care, not specialty care. And the faculty member, who was the medical director, was taking care of a patient with diabetes who had not been, taking his meds. He wasn't really doing too well in terms of his, medications, diet, and so on. And so this led the primary care provider to get worried about possible consequences of diabetes, including diabetic retinopathy. So as you may all know, diabetic retinopathy is a complication of diabetes that can lead to vision loss. It's actually for adults between the ages of 20 and 74, for working age adults in the US, it's the leading cause of blindness. It's completely preventable if it's caught early, and there's later photocoagulation therapy for that. And many patients who have diabetic retinopathy don't experience any symptoms until it's too late. And so for the gentleman that was being taken care of by the physician, the doctor referred him to the County of Los Angeles for specialty care, to see an ophthalmologist in person and get his eyes checked. And so the referral went through, and he waited and waited because the county on its part had patients coming in from their own ambulatory care centers as well as from independent FQHCs in the county. And so after a 4-month wait, he went blind. He lost his vision while waiting for care. And this was what the Dean of the College of Medicine considered sort of a crisis and an emergency, and asked if we could figure out something that we could do. And so we proposed a supplement to an existing NIMHD grant to look at teleretinal screening for diabetic retinopathy. We partnered with folks at the UC Berkeley School of Optometry. I had not led a teleretinal screening project before, but they had. And we essentially partnered with 6 federally qualified health centers to look at barriers to and facilitators of using teleretinal screening to essentially bring specialty screening into the primary care setting in 6 South Los Angeles safety net clinics. What we found as we moved on with the project is that we were able to screen a lot of patients. We were able to screen more patients than we ordinarily would. And a key factor was that we partnered with the County of Los Angeles so that any of the patients that are board certified ophthalmologists and reading the images, reading the teleretinal images, the digital retinal images, any patients that were found to have moderate or worse retinopathy would be seen within 3 weeks, which is a vast improvement over the 4-month wait that the original patient had. And so we found that it was pretty successful in getting more patients screened, but still a large number of patients didn't come in for screening. And we had a sociologist on the project who was who led focus groups and had in-depth interviews with patients and providers. And what we found was that in spite of the fact that the clinics had medical education, many of the patients thought that the eye exams were for glasses, not for something that resulted from their diabetes. There was that disconnect, even though the clinic was saying we have medical education, we're telling them about this. And so what we realized is that we had a large patient population sitting at home thinking that they were fine, not getting the annual eye exams, even with teleretinal screening. And so that led me to look at whether we could use machine learning or AI on known diabetic retinopathy risk factors that are in the literature, hemoglobin A1C, how long a person has had diabetes, and so on, whether we could figure out which of the people sitting at home thinking they were fine might have retinopathy and not know it, and help them to come in. So I've used the term machine learning a couple of times, and it's a form of artificial intelligence, which I'll get into as I go on. But essentially, this is using mathematics and statistical theory to create computational models that look at patterns in large amounts of data, for example, electronic health record data, and essentially use the patterns that are learned to make diagnoses or prognostic predictions for new cases that have not been seen before. So as a follow-on to the teleretinal screening study, we did an EHR-focused machine learning study that was funded by the National Library of Medicine to essentially detect diabetic retinopathy from data in patient records. And we compared the sensitivity, specificity, and errors under the ROC curve of different machine learning approaches. And based on that, we built a tool called DRRisk, which is a web-based tool for the safety net based on a deep neural network model. And we then identified and reached out to high-risk diabetic patients as part of our NLM-funded study who had skipped teleretinal screening. So our clinical partner for this larger study that followed the teleretinal pilot was the Los Angeles County Department of Health Services. As you probably know, it's the second largest municipal healthcare system in the U.S., second only to New York. Caters to 750,000 unique patients a year. 142,000 of those are uninsured. Between 2019 and 2020, it had about 85,000 patients with diabetes. And one of the ophthalmologists who was a part of our teleretinal screening pilot with the 6 FQHCs took some of the lessons that we learned from that pilot and launched a countywide teleretinal diabetic retinopathy screening program. And that's Dr. Lauren Daskovich. And so that is the primary modality for screening in Los Angeles County, teleretinal screening, because there are not enough ophthalmologists for everybody to have an in-person visit. And so the teleretinal diabetic retinopathy screening program has 10 optometrists who screen, look at digital retinal images, and then they have ophthalmologist overreads. And the goal is, the program's objective is to screen all DHS diabetic patients annually per guidelines. And that introduction of telehealth has improved the screening rates in Los Angeles County from almost 38% in 2012 to 64% in 2019. So it has been a success. So as part of our study, we planned to reach out. So we'd seen the increase that teleretinal screening had improved the rate of screening for diabetic retinopathy in the county. And we anticipated, the grant started in 2016, we anticipated that we would have about 10,000 patients who weren't coming in for screening and that we could apply machine learning and outreach to. Well, the COVID-19 pandemic hit, and that essentially changed our plans because the teleretinal screening clinics had to pause. So instead of 10,000 patients, we had 31,000 patients who had missed an annual eye exam as of mid-2021 because of the pandemic. So as part of the study, we sent reminder mailers to all 31,000 patients. We also sent, we had robocalls and text messages if the patient, after receiving the mailer, did not schedule an appointment within 2 to 4 weeks. We then applied machine learning to the data on the 31,000 patients and identified 7,500 that the machine learning thought was high risk. And what we then did was have bilingual Spanish and English speaking health educators and research assistants reach out to the patients, explain why it was important to come in. And we believe that this shows the potential for AI to guide targeted patient outreach in areas that have disparities in screening rates for DR, and that similar strategies could be valuable for other conditions in under-resourced settings. So I gave that context to before I get into what artificial intelligence is, just to show how we're using it at CDU. So what is artificial intelligence? It's computer systems or algorithms that are created to essentially achieve or accomplish tasks that would ordinarily require human intelligence. And those tasks include learning from data, recognizing patterns in data, making decisions, and understanding natural language. And I always stress this, that AI in medical care is intended to assist or augment healthcare professionals' abilities and not to replace them. So examples of artificial intelligence include machine learning, which I've already talked about, including deep learning, natural language processing, and generative AI, which is all the rage right now with ChatGPT and Bard and so on. So large language models or LLMs. And then I want to introduce the concept of narrow and strong AI. So narrow or weak AI is essentially designed or trained to perform specific tasks. It doesn't possess any consciousness or any kind of general intelligence, but narrow AI can perform better than a human expert in a very narrow domain. So there's lots of examples of narrow AI in medicine that I'm sure that many of you are already familiar with. We have AI algorithms for medical imaging and diagnostics, algorithms for predicting, sepsis or the risk of hospital readmissions. We have AI chatbots for patient appointment scheduling, for checking symptoms. managing medications, mental health support. There's Path AI, which uses machine learning to help pathologists diagnose diseases from tissue samples. Dragon Medical One, which understands and transcribes clinicians' spoken language as a way to update the patient medical record just using speech. Deep Genomics, which uses AI to understand genetic mutations and to develop targeted therapies that could help individuals. Atomwise uses machine learning to predict potential new drug targets, and this is an exciting area of drug discovery that's facilitated by AI. And then we have, robotic surgery. So the Da Vinci surgical system robot essentially uses AI to assist surgeons with minimally invasive surgeries. So I've talked about narrow AI, and then there's also a notion of wide or general or strong AI. And this would describe an AI system that has generalized human cognitive abilities and could find a solution without human intervention. And this is a theoretical concept that's not yet fully realized, but it's one that causes a lot of alarm, and a lot of people are kind of worried about the potential for wide or general AI. But we are not there yet. So there's several types of machine learning. I mentioned that machine learning was a form of AI. One is supervised learning, where we teach a computer how to learn by providing labeled examples with correct answers that it can learn from. Unsupervised learning, where we have the computer learn patterns by itself from unlabeled data. And then reinforcement learning, where we're going from situation to action by maximizing a reward or a reinforcement signal. So an example of this would be teaching a robot to avoid obstacles on a factory floor. So for supervised learning, machine learning, just a simple example to describe what this is, and I apologize for those who are already familiar with this. So essentially, if we wanted to teach a computer how to recognize cats and dogs from lots of pictures of cats and dogs, we would label, we would show the computer many pictures of cats that are labeled as cats, so let it know that they were cats. We would show it many pictures of dogs, and they're labeled as, those pictures are labeled as dog pictures. And then the computer would try to find patterns that make a cat different from a dog. So perhaps cats have whiskers and dogs don't, and any other features that distinguish the two groups. And then what we do is we test with supervised learning. We test the computer to see how well it would learn by showing it a picture of a cat or a dog that it hasn't seen before. That's not in that training set of lots and lots of pictures that it already saw. So we're trying to help it to make a prediction on a previously unseen case. And so we ask it whether the picture is of a cat or if it's of a dog. If the computer makes a mistake and it calls a cat a dog or calls a dog a cat, we tell it what the right answer is so it doesn't make that mistake again. And so as time passes, the computer gets better at recognizing cats and dogs as it keeps learning from the pictures and the feedback that it receives. So that simple example, was just to set the stage, but the medical examples are pretty complex, so where supervised learning is used. And one example is breast cancer detection using convolutional neural networks from mammographic images that are labeled with benign or malignant tumors, and helping to identify breast cancer tumors. So unsupervised machine learning, in this case, the computer is learning how to recognize things without those labels. So in the previous example, we had labels of cats and labels of dogs. Here, there's no guidance, there's no labels. So if we wanted to teach a computer to organize images of a variety of fruit, what would happen in the case of unsupervised learning is that the computer might note that fruit with similar shapes or sizes or colors maybe belong together and group them together. And then the computer would keep up the grouping process until all the fruits are in a particular group. Now, there's no sort of accuracy measure for this. It's a little bit subjective, right? And so medical examples of unsupervised machine learning include clustering. So we might want to cluster patients who have similar symptoms or risk factors to find subpopulations of patients that might respond better to certain treatments. So we could test that hypothesis. And there's a published example of clustering, unsupervised learning, clustering where clinical cancer data found significant association between clusters of prognostic groups that had chronic lymphocytic leukemia and the patient's survival outcomes. And the publication is listed there. So for reinforcement learning, which is the last form of machine learning that I described, this is kind of inspired by the way humans and animals just learn from actions or past experiences to make better decisions. So an analogy here is if you were trying to get a high score on a video game that you had never played before, that you know little about, somebody gave you the video controller, you might try pressing the different buttons, try different actions until you realize which one would lead to a higher score. And that would lead you to pursue more of the actions that lead to a higher score in order to maximize your score and potentially be the highest score on that video game. And so the concepts behind reinforcement learning are, you have an agent that's a learner or a decision maker that's essentially trying to achieve a goal in an environment. An example might be a robot. If we go to the example of trying to teach a robot to avoid obstacles on a factory floor, the environment would be the external system that the agent or robot is interacting with. So a factory floor with obstacles could be one. And the state describes the current situation or the configuration of that environment. And what the agent is doing is picking an action to take based on the current state, based on the current environment. And after taking an action, the agent receives a reward based on whether the action is judged as good or bad. So it gets negative or positive feedback from the environment. So a medical example of this is what we've just previously mentioned. Reinforcement learning is used to train the robotic arms that are used for minimally invasive surgery. So like with the Da Vinci robot, the robot learns optimal movements and surgical techniques by receiving feedback on its performance. So you've probably all heard of generative AI, and prior to 2022, most of the AI that was used in the biomedical domain was non-generative AI. This is before ChatGPT came on the screen. It was mostly supervised learning, and generative AI has exploded on the scene since then. So it uses a combination of unsupervised learning as well as other techniques to create output, whether it's text or images or music. And with large language models, they essentially train on huge amounts of unlabeled data, and they learn patterns and structure in that data without being told what to look for. And they do pretty well. It's fairly exciting what generative AI models are able to do. And once they're trained, they essentially generate output by predicting what comes next in a sequence. So the next plausible word in a sentence or the next plausible paragraph in an essay, for example. Unfortunately, one of the things that they may do is hallucinate. So they may generate information that's plausible, but it's incorrect or nonsensical. So if you ever try to use ChatGPT and ask it to come up with a citation for a particular area, it might actually come up with a made-up paper that includes names of experts in that area, but they have never published together, and there's no paper with that title when you go into PubMed to look for it. That's an example of hallucination. And this is really problematic in the healthcare domain where accuracy is so crucial. And so it essentially means that human oversight is still necessary in the, is actually not still, very necessary in the healthcare domain. So essentially AI is suggesting and humans sort of verify and decide. So there's lots of AI benefits for patient and healthcare providers, enhanced diagnostic accuracy, the ability to have personalized treatment plans for patients, the ability to automate routine administrative tasks that potentially could help healthcare providers focus more time on their patients rather than on admin tasks. For people with chronic diseases, improve patient monitoring through wearable devices that are enhanced with AI, and predictive analytics to prevent crises and to provide proactive care to patients. Now, with the benefits come a number of concerns. So there are concerns around data privacy and security. So when ChatGPT was first rolled out, for example, a lot of hospitals were interested in using it. But one of the concerns was you're feeding, you don't want to feed data into a large language model that's being used generally by the whole world because your patient data is subject to HIPAA protections. So lots of hospitals have essentially made arrangements to have siloed implementations of generative AI so that the data learned from a hospital system, it doesn't go get seen beyond that hospital system. A fear, one concern is that a fear that AI might make autonomous decisions, and this is something I hear about quite a bit. And again, my view is it's intended to augment or assist, but not to replace humans, and that human oversight is absolutely necessary in healthcare. Another concern is the lack of transparency. Many of the most successful AI algorithms are considered black boxes. They can't really tell you how they achieved the results that they came by. Now, there's a whole new area of exploration in informatics and computer science of explainable AI, where you could take a black box model, but have another model that can explain how the black box model came about, its decision making, in a way that might satisfy a healthcare provider who is skeptical about the suggestions being made. There's also issues of fairness and bias in AI because, like it or not, AI essentially reflects the biases present in the data that it's trained on. We've seen examples in the non-healthcare domain of facial recognition systems adopted by police in several cities. We had cases in Detroit and other places where several people were arrested, in mostly Black males. And essentially, the problem was that the data sets that were used for training did not have data on a lot of people of color. And so the models produced are not able to adequately distinguish and may make recommendations about guilt of people who are not involved in a case. In many of these cases, people were able to show that they weren't anywhere near the area. But you could imagine a situation where somebody was sitting in their home and can't provide an alibi and now has a sort of a nightmare situation to deal with. So AI reflects the biases present in the data it's trained on. I use an example in the classes I teach our students that, Loma Linda here in California is a blue zone. And so if I went to Loma Linda Hospital, so you have people living to 100, 101, 102. They're the most long-lived. They're very healthy. If I took data from Loma Linda Hospital to create a model for heart disease prediction, and then I took that model and plunked it down in South LA or in Baltimore or in Harlem, I might underpredict heart disease, and that would not be a good thing. And so we have to be careful when AI developers make claims about the generalizability of their tools that are really not supported by reality. There's a lot of excitement, but there's a need to verify. There's a need to really rigorously test the claims made about models. And there's also the issue that the excitement about the advances in AI in healthcare may overshadow the reality that the benefits don't accrue to all patients. So there have been several papers that sort of highlighted some of the concerns that I list. So Ziad Obermeyer and others essentially looked at, published in Science in, I believe it was 2019, an article showing that an algorithm that was commonly used to assign care had racial bias because it was using cost as a proxy for needs. And in the data sets, white patients had more healthcare costs because they had more access or better access to care. And so it ended up that Black patients who were sicker were assumed by the algorithm to be healthier because their healthcare costs weren't as high. And that's problematic. Another study that was published relatively recently was one that showed, Judy Gachoya and others, including Leo Selly at MIT, basically ran the study that demonstrated the ability of AI, convolutional neural networks in this case, to accurately assess a patient's self-reported race from X-ray, CT, or medical image data. Now, this data did not explicitly include racial information that a human expert could discern. So the humans could not figure out how the algorithm was figuring out the self-reported race of patients accurately because the data was not labeled with race in any way. And that raised concerns about unintentional reinforcement of racial biases in medical treatment if the algorithm knows something that the providers don't even know that it knows. And also, again, the lack of transparency in terms of mechanisms that AI algorithms use to identify race, in this case, are poorly understood because they couldn't figure out how the algorithm was correctly assessing the race of patients with data that's not labeled in any way by race. And then there's the potential for violations of patient privacy with that this brings up. So Tina Hernandez-Broussard and others have essentially recommended to dismantle race-based medicine and have a race-aware approach to clinical decision support that definitely considers social and environmental factors like structural racism, as well as social determinants of health, which you all have been discussing. And so, including social determinants of health in AI models may improve accuracy over utilizing clinical data alone. So data on socioeconomic status, access to healthcare services, healthy food, neighborhood and the built environment, educational attainment, and so on. We've had in our work some success with using, so based on EHR data, we can map to the CDC's Social Vulnerability Index and include that in models. We've also been able to map to the University of Wisconsin Area Deprivation Index, and that adds more richness to the data for predicting certain medical conditions. So, social support networks are also important, community engagement, and individuals' experiences with discrimination, because if you're doing a model that is in the mental health domain, for example, that's important to know. So a publication from 2022 found that machine learning models that incorporated social determinants of health versus traditional models that did not were actually particularly good for predicting the risk of in-hospital mortality after a hospitalization for heart failure, particularly in Black adults. The interesting thing, though, was that the social determinants of health were not particularly useful for prediction for non-Black patients. So that's something that needs to be explored a little bit more. But it really improved risk prediction of in-hospital mortality after heart failure hospitalization in Black patients. So we've talked about benefits of AI and some concerns about AI. And so if you have concerns, the next thought, at least in my mind, is, well, what about regulation? And so we have a very interesting situation where the European Union last year had the AI Act pass their parliament in June. And then this year it was formally adopted. And it's billed as the first ever comprehensive legal framework on AI worldwide. It focuses on privacy protections and data rights. It establishes governing bodies for AI in the European Union. And it classifies AI risk as unacceptable. So unacceptable would include AI that performs cognitive behavioral manipulation or social scoring, or AI that compiles facial recognition databases by scraping the internet for facial images or scraping public CCTV footage for facial recognition info. There was an article in the New York Times, I think last year, that talked about a company in the US that is doing exactly that. So in the European Union, they would not be able to do that. So it classifies AI risk as unacceptable, high, limited, or minimal, and it bans AI with unacceptable risk. In the US, the AI regulation is fragmented and really sector specific. There's no overarching regulatory framework the way that we see in the European Union. The FDA, of course, does regulate AI and machine learning used in medical devices and AI, essentially software as a medical device. So the area of diabetic retinopathy is actually one of the areas where a lot of machine learning models have been approved by the FDA and monitored. But one of the things that we need to think about is when an AI model is approved by the FDA, what comes next? So if it's a drug, you do a follow-on study. With machine learning, what we know is that, a hospital, so if a hospital is using machine learning for prediction for a particular condition, the hospital population changes over time. So the AI models also have to change. You could have a population that was young and it gets older, and the conditions of diseases and risk factors, all the things that went into building the original model probably need to be updated. And that's something that we need to think about over time. And it's not clear that the FDA is taking on that part of the regulation and oversight. And the U.S. Congress recently had, the Senate had a bipartisan group that's looking at injecting $32 billion into AI, into essentially making sure that the U.S. is a leader and competitive in this space. But there's no mention of regulation in that. The idea is just to have us, be as advanced as we can be, but I think there's a need to also look at regulation. And I'm a big proponent of AI, but I think in many cases it does need to be regulated. So in summary, I've talked about AI in healthcare and the fact that it can be a very useful tool in the push to reduce or eliminate health disparities and to achieve health equity. It provides many benefits that I've mentioned for patients and for providers, but it also has raised concerns about transparency, about fairness and bias. And I talked about the fact that inclusion of social determinants of health can improve AI models used in healthcare. And the EU has decided to regulate AI through this new comprehensive AI Act, where US regulations are a little bit more fragmented at the present time, where the FDA does focus on regulating AI and machine learning used in healthcare. So I'm really happy to take any questions that you may have.
Thank you so much. Yes. Thank you, Dr. Oganyemi. Really appreciated that talk. And Dr. Ayala, turn it over to you.
Thank you, Dr. Oganyemi. It's amazing presentation. My name is Guadalupe Ayala, and I'm definitely going to come up and see you because we're both RCMI institutions, and we have a lot of data we need to explore together. AI is not my area of expertise at all, and it's interesting to be selected for this because I'm actually technology phobic when it comes to certain things, and this is one of them. So I appreciated the broader introduction to artificial intelligence, the various types, and the machine learning. I also appreciated your comment regarding generalizability because that's definitely one of my concerns, so I'm glad it's on folks' radar. I think in the context of this discussion, our discussions today, which I don't know if you were a part of, but it was really good to end on this presentation because we talked a lot about social determinants of health, social drivers of health, other data that we can use from electronic health records, common data elements. And so I guess one of my questions is around the issue of data quality that's being used to derive those estimates. And I guess as I am exploring EHR data more and more, I increasingly am skeptical about it. So if you can comment maybe a little bit about that.
So there's no question it's definitely a challenge. So data collected at the point of care is not, research quality data by any stretch of the imagination. And so that is a concern. It is a valid concern. There's a lot of effort that has to go into data cleaning when you're using EHR data. And in fact, for our machine learning project, the data cleaning consumes most of the learning the models is not the difficult part. It's the data cleaning. However, I still think that there is value in developing models from care as it occurs. With the caveat, of course, that yes, a lot of attention does have to be focused on data quality and data cleaning.
And building on that, when we were talking earlier about common data elements, and we were talking about the need for more nurse-led and other practitioner-led efforts to identify those common data elements, I think they could really contribute to this. So broader question, maybe other folks know, but I'm curious, is there research around practitioners' receptivity to using that information in the clinical encounter?
It's actually funny you would mention this. I think it was either Kaiser or Cedars that recently had a number of nurses that were saying, we don't want, unaccountable AI that hasn't been validated giving suggestions about anything. But what we've found, especially with the introduction of ChatGPT, there's a ChatGPT effect where people are actually generally more likely to think that computers have the right answers and to defer to computers in certain cases where they probably should not. But so receptivity, it varies, obviously. There are those who have embraced AI and those who are, I think, rightly skeptical, because I think there are a lot of claims being made right now that AI is definitely not perfect. And there, as I've said, there needs to be, monitoring of systems over time. We need to look at the quality of data sets. We need to look at the diversity of the data and the data sets. Are you taking data from community, in Alaska and trying to apply it in Baltimore without any regard for any kind of differences in the prevalence of diseases in both communities and so on? And so I think there needs to be a lot more skepticism about some of the claims being made about AI, but definitely I think it has numerous benefits. And the interesting thing is that patients also, we've had conversations with patients where we found that a lot of patients in this area who are more recent immigrants see technology as a good thing. And so, any advance in technology is great. It's moving into the future. Whereas those who've lived, who've been here for much longer are skeptical. They're like, you're basically trying to shortchange us in some way or form by using, people who are like, I would prefer the traditional, see my healthcare provider. They know what they know, and I don't need all this newfangled technology in between. So it's really interesting that there's basically a wide variety in reception, AI reception.
Thank you. That might explain it, because I'm definitely a second generation immigrant, so I'm not innovative in that sense. But I will close by saying two things in terms of how we're using machine learning that I do see some value in. One is we used it to analyze data that was based on eye tracking data that we used in grocery stores. And what was really interesting related to your comment about newer immigrants is that we were surprised that families had no problem wearing it, in part because they wanted to know where their child had the most influence in the grocery store so they could better understand how to address the issue of nudging. The other area, and I was talking about this with John earlier, is I really think we should try and use this to better understand the impact of our research. So there are people that argue that science is not science until it's published. And so how are we using machine learning to better understand the contributions we're making in our published work? So I would love to see some work in that area and open it up for any other discussions. I know we do have experts in the room in this area.
So this is not my area of expertise, but I do want to do two things. First, I just want to say that was a fantastic presentation, and I learned so much, and so thank you for that very much. Two things. I think the question for me is, what is the strategic opportunity for nursing, and where can nursing shine, and what can we potentially add that isn't better suited or already being addressed by other groups that are larger, that actually do this better, et cetera. And so that's kind of a question. One example that I want to lift up, it didn't come up in the terrific papers, but there was a really strong paper in Health Affairs that was a scoping review on mitigation of racial bias in the algorithms. And the lead author on that paper was a nurse. It was Dr. Michael Carey from Duke University, who has been thinking about a framework for how nursing can lead in the application, of AI to the health sector, and then where are the problems, and then what are the mitigation strategies. I learned a ton reading his review, And I think we need more of that kind of contribution from nursing.
Yeah, also thank you for making the very complicated concept simple for everyone to understand in the space of AI and machine learning. I can see kind of huge potential for AI. We see the hype in the society. We also see the doubt, the skepticism. And I think some of it is the lack of knowledge, what is truly AI. And, it's very sad for people to think, Chat GPT trained by nurses can replace nurses. Or on the other side, nurses don't want to touch AI, because I think we need to be in between. And how can we really leverage and, use AI to augment? Thinking about nurses, I think one of the areas AI can hugely support nursing is in the realm of nursing documentation. It's taking nurses half of their time in front of a computer. So how can we, leverage AI to reduce their time in front of a computer and bring the nurses back to the bedside? And the other area, it's the innovative models of care nurses and nurse practitioners can lead. And one of the most interesting area, I think, is nursing profession being sort of the most trusted profession rated by the American public. And we all talk about the mistrust in science and also the mistrust in AI. And how can we marry the public trust in nursing and nursing profession? I'm interested in the sort of the nursing the loop, human in the loop AI to, always have that oversight or embed nursing knowledge, nursing oversight into the algorithm. I see that as an area for nursing and nursing science, but also educating nurses and nurse practitioners so that they can really be empowered to lead the next generation of clinical decision-making, clinical care that will be augmented by the AI. So the next strike we can have is not about, no, we don't want AI, is that we actually use AI every day, but it needs to be led by nursing.
Right.
Thank you.
Any other comments?
Long before all the newspaper articles about it, we've been using it. It's fascinating to me. We've been using AI for a really long time in all kinds of decision making. I mean, it's, from what grocery store coupons get suggested to you. I mean, it's present somehow or another. The rollout of Chat GPT made, which interestingly did have a very rapid, I'm not telling Amalola anything that she doesn't know already, but it did have a much more rapid adoption or at least site visit trajectory than other technologies when they were rolled out. But there are lots of instances in AI that make our lives easier in many ways. It's an artificial intelligence system when streetlights are programmed to give you a green light when there's no other traffic going in the other direction. Like that is an artificial intelligence system. We have that in our lives every day. We've had that for a long time, but somehow or another, it's been rolled out in this way now because of Chat GPT and suggesting to people that they're all going to lose their jobs. And so I think nurses can play an incredible role in, because they are trusted in sort of saying, yeah, but here's how we use it. And actually, here's how we all use it every day. And here's how we use it in the clinic. And here's how it helps us do a better job in the clinic. So, everybody thought the whole world was going to end when the internet came around. And then, we were okay. The statisticians are not trying to take over the world. We're just trying to help make it better. Right?
Yes.
Well said. Well, and I appreciate that point too, because a lot of the discussion, today is on healthcare, right, in this section of the agenda, but AI is everywhere with tremendous implications for health, and it plays out in social determinants of health as well. So it has, certainly in healthcare, but much broader as well. So thank you for that point. So Dr. Aganyemi, we appreciate you joining us. Thank you for your thought-provoking presentation and the great discussion. Thank you.
Thank you so much for inviting me.
Thank you. All right, so we have 2 agenda items left. We have a really important agenda item on a new concept we want to put forward around AI for your feedback and consideration. And then we do have the last agenda item of open session is just a time for open discussion. So I know we've had a lot of rich discussion, but if there's anything else you want to put on the table today or raise, that'll be the time. So do you want to take 5 minutes to stretch and come back for those last couple of items? I see some nods, so we'll see you. I'm going to give you 6 minutes, all right? Yeah, all right, 6 minutes. All right, welcome back, everyone. We're going to move on to our next agenda item, concepts. So as you know, in your role as advisory to the NINR director, you are NINR's source of non-governmental advice on research directions and scientific priorities. NINR seeks counsel's advice for long-term planning at an early stage by presenting concepts for clearance. You might recall a concept is the earliest planning stage of an initiative before developing a funding opportunity. A concept describes the background, objectives, and potential mechanisms for the initiative. Any approved concept may or may not turn into a funding initiative based on a number of factors, including funds availability. So summaries, again, as always, of today's concept were made available in the electronic council book for your review in advance of this meeting. So I am very pleased to welcome Dr. Libby Bowen, who will present a concept on social determinants of health and AI to advance health equity. Turn it over to you.
Thank you. So this concept is called Social Determinants of Health in Artificial Intelligence to Advance Health Equity. And the concept team includes myself, Dr. Karen Huss, and Dr. Lee Willis. So artificial intelligence is the design and study of computer programs to be intelligent and includes a wide range of techniques. AI applies traditional statistical forecasting methods such as deep neural networks, natural language processing, random forest, and decision tree algorithms for predictive and analytical purposes. There's optimism that the application of AI can provide substantial improvements in all areas of healthcare, from diagnostics to treatment. There is already a large amount of evidence that AI algorithms are performing on par or better than humans in various tasks. For instance, in analyzing medical images or correlating symptoms and biomarkers from electronic medical records with the characterization and prognosis of the disease. However, the use of AI in health is controversial due to concerns about fairness and transparency in model development, interpretation, and application. There's also a growing body of research on bias in AI and recognition that AI has perpetuated and even exacerbated inequalities across many aspects of society, including medicine, criminal justice, and finance. So NINR adheres to the NIH-wide conceptualization of SDOH. Social determinants of health include the conditions in which people are born, live, learn, work, play, and age, and the wider set of structural factors shaping the conditions of daily life. Those structural factors include social, economic, and legal forces, systems and policies that determine opportunities and access to high-quality jobs, education, housing, transportation, the built environment, information and communication infrastructure, food and healthcare, the social environment, and other conditions. Social determinants of health have a significant impact on health outcomes. Artificial intelligence research must include inter- and multidisciplinary team experts in health. Nursing science conceptualizes health challenges within the context of people's lives and living conditions and is well positioned to make important contributions to AI research.
The statement of the problem. AI research lacks inter and multidisciplinary team experts in health. Many AI systems lack representative, diverse data and fail to examine how the inclusion of SDOH may affect results in model interpretation. Many AI systems do not include SDOH, though research shows including it significantly improves model fit, outcomes, and predictions. And when social determinants of health are utilized in AI algorithms, data inputs rarely go beyond the inclusion of individual level SDOH proxies, such as race or ethnicity, gender or age, which do not capture the wider set of structural factors shaping the conditions of daily life. And reducing SDOH to demographic conditions can reduce data and skew results. The purpose of this concept is to understand and address SDOH in AI models and systems and use SDOH to improve AI models and systems to reduce health inequalities and advance health equity. This concept promotes SDOH research, utilizing a variety of methods and measures to understand and address known biases in AI, and to understand how SDOH may be used in AI to optimize health and advance health equity. Examples of research to address the gaps could include research to understand how to use SDOH in AI to improve health outcomes and reduce disparities, research using inter and multidisciplinary teams with health, SDOH, and equity expertise to inform AI algorithm and system development and implementation to advance health equity and optimize health outcomes, research to promote transparency in AI by providing information on SDOH inputs and other data characteristics, and research that provides for the continuous oversight of AI systems using SDOH. And that's it. Thank you.
Okay, thank you. I believe Dr. Fitzpatrick. Yeah, thank you.
Thank you. I was excited to see this concept just because data science, the train has left, and I think NINR really does need to get on board with this. I was excited because I see this initiative as addressing the lenses of systems and models of care. We haven't seen as many concepts specifically that could be fitted into that category, and also prevention and health promotion. I was going to make the comment that professional societies have already taken the lead on this. Many of you are aware of the American Heart Association's new algorithms. It's the equation for the risk of basically heart disease. They've removed race because race is not a biological variable, but they now have options where social determinants of health reflected by your zip code can be included as an optional variable in that prediction model. And so they're using the social deprivation index of basically your zip code where you live to predict heart disease. So I think, that's one example. The American Thoracic Society has gotten away from race-based lung function equations, but it's raising issues about either under or over treatment of patients who are going to fall into different categories as a result of that change. So there's lots of opportunities for research. I think there's lots of opportunities for partnership with other institutes. I mentioned Heart and Lung, but clearly others as well. And I think this is exciting because many of our healthcare institutions are actually doing this. There's all sorts of quality-based initiatives. One example is in our emergency department. We're rolling out Epic medical records, machine learning algorithms to try to predict patients who have sepsis. And instead of sitting in the emergency department and then getting very, very bad outcomes as they sit there for hours and hours, like early identification of these patients. So hospitals are interested. There's a lot of quality work around this, but really integrating work that organizations are doing from a research perspective, I think is very, very vital and very timely. So thank you for this.
Great. Thank you. Open the floor for other comments.
Since Vincent said I didn't speak up last time, and I probably should have, I'm going to do it now. So first of all, I'm so glad to see that you all are taking this step. And as I've been thinking about this issue, some of the things that we've been thinking about include, this is a multidimensional issue, health inequities. It requires multiple lenses in order for us to really create more effective AI tools. that will help us succeed in advancing health equity. The other piece is interventions at the social or policy level, as we have seen in recent research, more so than individual level interventions are more likely to advance health equity. So some of the things I've been thinking about as I've been hearing this is that we need to prioritize research from regions or populations with more substantial academic output, potentially because we're overlooking underrepresented communities. So as we're moving forward in this concept, I really think it's important not just to pull, research from PubMed in general, but to target them by regions of the United States, if that's what we're really trying to target, as well as population groups. I think another area too is the idea of inclusion of gray literature and non-English sources. Oftentimes we're focused on the English materials, and from a global health equity standpoint, I think it's important to also pull sources from there. So those are some areas that I thought might be interesting. I have other ideas as well as we move forward, but just something to nibble on.
Any other reactions or questions in terms of areas to focus on or?
Shannon, this is Pat. I just want to tell you how happy I was to see this on the agenda, because it's, as Anne said, we're all thinking about AI so much. One of our clinical faculty, Associate Dean of Clinical Affairs, just became the Associate Dean of AI, in the school. And so it's happening in the clinical practice, and it's happening in research. And so I'm very happy to see NINR taking some leadership about this with social determinants of health. So thank you. I don't really know where to focus on. It's not my area, but I'm very happy that other people will be focusing on it.
I mean, I think the focus is that the models are only as good as the data that go into them. And if you're focusing on a health outcome, who better to help design the model than a healthcare professional? And, nurses use the medical record. I mean, if it's Epic-based machine learning, who do you want to be on your team as the nurse that is very familiar with where to click and the drop downs? So, I mean, I see us as a vital component of those teams. I mean, one thing that actually makes me really happy is our institution is hiring nurses on data science teams. The healthcare environment, this is now a new position. I can't remember the title, but I actually had someone wonderful leave my team to go do this. So happy for her, but this is the direction it's going. So I think the use is in the inputs, and we're only as good as the inputs.
So I agree exactly with what you said, that the models are only good as the data, and the models are only as good as the substantive statistical foundation upon which the models are built. So if you don't have people who are really, if you don't have people who are really thinking through the biological plausibility, the reality of how the clinic works, the reality of of how people move from an emergency department into inpatient, or being seen in a clinic, getting referred to an emergency department. So artificial intelligence systems still need that substantive expertise. They need really good data where somebody's doing a serious evaluation of what constitutes good data and comprehensive data, and not data from Alaska being, as I think it was our previous speaker, data from Alaska being applied in Baltimore. And it requires a very strong statistical foundation. And I think there's an opportunity for NINR to bring some people who have not been in the NINR researcher fold in to work collaboratively with people who are in the NINR fold. So you see a lot of epidemiologists who are part of the NIH portfolio, but you don't see as many statisticians or computer scientists. And we will make more progress if you have more statisticians and computer scientists. And I don't say this only because I'm a statistician. They're.
So I'm gonna say what several others have said, and that I'm not an expert in this area, but I love the concept and I'm very excited about it. And I think maybe some of your comments they resonate with what the point I was going to make, and that is that makes me think that perhaps NINR should consider some parallel focused T32 calls, some R25 calls. So instead of people trying to play catch up with these concepts and trying to sort of retrofit them into what we're doing, we have a steady stream of nurse scientists and others doing nursing science that are learning this way from the start. And so that they are positioned to be much more agile and directive of where things are going.
You know, along those lines, the SBIR mechanism too. I mean, all these wearables, they're interfacing with clouds. I mean, the input that you get on your smartphone is all AI. I mean, there's a cloud-based operation, there's an R&D based operation. So I think there's opportunities there as well. I mean, how can nurses use wearables, you know, coupled with AI to improve outcomes? It would just be one example.
I also would like to see more nursing in this concept, or moving beyond just developing models, incorporating SDOH, but like move into nurse-led and NP-led models of care in advancing health equity with, you know, the previous concept we talk about is need to go beyond screening or data, need to go to like how to use data to drive insights and action, and kind of move it one step further to be this, you know, new models and leveraging AI as, you know, clinical decision support for nurses or NP, to develop a new model of care that is using AI augmented care. Maybe that doesn't fit exactly with this particular one, but I think if we want to be like even bolder to like go toward intervention community based, which is where our nurses already are doing it in the health equity work, to not just stay in, you know, the data developing models, but how to move it into an intervention.
It's this NIEHS issued a RFA a number of years ago called Prime. I forget what Prime stands for, but it was all on how do you think about mixtures. And I was the Ann Fitzpatrick when that concept was brought to council at NIEHS. And one of the things that they did in that is that they required, in order to attract some more people who were not already in the NIEHS portfolio, they required somebody that there be an interdisciplinary team that included someone with statistics or computer science background, and then somebody with the kind of background that Jing was just talking about, the really solid grounding in nursing science. Well, they didn't do it for the NIEHS one, but you could imagine something. It might be worth it to just find that RFA. I know that there's a website on the NIEHS page for Prime, and you could find the RFA.
But I think where we get stuck is when we think about AI, we think about computers, like sitting in front of computers and computer input, but really it's just a tool to mine complex data. So what we should think about is complex data. So a waveform is a source of AI. Telemetry is a source of AI. Respiratory rate, like really complex variables that rather than reducing it down to a moment in time, I mean, a digital stethoscope, like that's one of the advantages, right? Is instead of just 10 seconds of listening to breath sounds, you could monitor it for maybe a minute, you know, and some of these devices, it's even more. So I think about AI as complex data and how can nurses contribute to the analysis of complex data. And for me, that's a way to simplify it.
Well, if I may tag on to that, it's also a tool that lends itself to teaming, you know, human machine teaming. You see it a lot in software programming, like the code is a hobbyist. So you can in a pair use this AI to help expedite some problem solving and programming those kinds of issues. And we should be able to apply that to other things as well.
And you can even do secondary analyses. I mean, you have these rich data sets. I mean, so many variables that are really amenable to machine learning and other approaches. So, what existing data, maybe through some of the consortiums, the Compass initiatives and so forth, there's ways to think about how to focus it in nursing. But again, it's just a rich data source. That's all you need.
Other thoughts? This was really helpful. Thank you. This is really good feedback. Okay. All right. So thank you, Dr. Bowen. Appreciate your and the team's work on that. All right. So before we end open session, just want to open the floor for any additional thoughts or comments or things you want to see at a next meeting. The floor is yours for one more minute or as long as you want. Are we good? I know we've had a lot of discussion today. It's been great. This has been such a terrific meeting. Really appreciate your engagement and so valuable. We've got so many note takers in the room. And then, of course, we have the recording. So thank you. Yes.
I hate to be the one to extend the minute at the very end, but forgive me. So obviously, I'm sort of preaching to folks that are aware of this already, but I think one strategic opportunity that is forthcoming is the release of the Unequal Treatment Revisited report. And so I think that will be announced soon in terms of, what the National Academies has worked on. And I think there will be a lot of opportunity for NINR within the context of that report. And given that NIH is the sponsor, I guess my question, maybe for another time, but certainly wanted to be on record, is how can NINR sort of help lead in terms of whatever those findings are?
Whatever they are, you don't know, but we'll know soon. No, couldn't agree more. Thank you for putting that on the table. I think that would be, maybe we could lean on you to present at September's council to share some of those recommendations and give us time to reflect as a group on the implications for us at NINR. That would be terrific. Thank you. Yeah. Other things you want to put on the table? We'll stay all night, right? Like you can put as many things on the table. Okay. Well, you have our email and our phone numbers, and so you can call us, of course, at any time. So we want to end then open session. Again, thank you for your time, your attention. So we're going to adjourn, and I'm going to be very precise. It's 3:22 Eastern. So how much time do you want? We do need to transition some seats. How much time would you like before we move into closed session? Just kind of look around the room. Are we good with like 5-ish minutes? 5-ish? Okay, so let's do, I'm going to give you 6 minutes. No, I'm going to give you 6 minutes. We'll do 3:29. 3:29. Okay.
Yes, okay.
We'll see you at closed session 3:29. Okay, goodbye.